What happened?
Everybody's here. I love when you click admit all and everyone magically appears. It's one of the cool things about Zoom.
Wow.
Hello, everyone.
This is a lot.
Nice to see you. Nice to see you. All right, so we'll just give everyone a minute to connect audio and pop on here. All right. I see Kelly. Hi, Kelly. Okay, I am loving looking at your faces. I'm actually going to share my screen for a moment, though, just to start with our technology and remind everyone of our Zoom etiquette and how we do things here. So bear with me 1 second while I share my screen. I don't know these people. This came from the Zoom website, but I'm going to talk you through 2 slides, and those of you who participated in this meeting in June have seen these before. Actually, I'm going to start by saying I'm Jamie Strauss-Clark and I facilitate this work group, so welcome everyone. I'm just going to walk us through the Zoom etiquette. There's a separate one for members of the public, and I don't know why my dog decided he was going to start barking right now. I apologize for that. So let's start with our Zoom work group members. We actually, it turns out we set the controls so everyone is muted on entry. So we're going to be muting and unmuting you today. So you don't have to worry about keeping your mic on mute. But do please keep your video on if you're a member of the work group. That is how it makes it a lot easier for us to facilitate if we can see the faces of the work group members. Members of the public, I'm going to ask you in a moment to turn your cameras off until we get to public comment. But work group members, please keep your video cameras on. And the way to do that is using the controls in the bottom left corner of the screen. I know most of you are probably Zoom experts now, but just a reminder that that's where you go. One suggestion I have for you is in order to see as many work group members as possible, you might want to put your screen on gallery view. You find that in the upper right-hand corner of your screen. As a reminder, because of the number of people participating today, we have disabled the chat function. So you should be able to send a chat to one of the co-hosts if you're having some trouble and need help, but otherwise we're not going to be using the chat for our deliberations. We're going to, as we did last time, use the raise our hand indicator to indicate when we want to speak. This will just minimize us talking over each other and make it a lot easier for the facilitators. And just a reminder of where you find that control. It's a little hidden. What you want to do is click on the participants button at the bottom of your screen and it pulls up a new window and you should see a blue raise hand icon. So just click that. Your facilitators will be able to see the order in which you've raised your hand and we'll call on you. And then one of us will unmute you so you can make your point. Okay, members of the public, I'm going to ask you to also keep your mic muted, which we have control over, so you don't have to worry about that. And I'm going to ask you to stop your video for the working portion of the meeting. This is really important because as you saw when you came in, there are many people on the screen. And in order for us to be able to ensure that we're calling on just work group members during the working portion of the meeting, that's the best way for us to distinguish between work group members and members of the public. So please do help us out and keep your video cameras off. When we get to public comment portion, the person giving the public comment, we're going to ask you to turn your video on, and I'll talk you through that in just a moment. But for now, if you could click that stop video button in the lower left corner of your screen, if you are a member of the public observing the meeting today, we would appreciate it. Same other information, if you want to be able to see as many work group members as possible, click on gallery view in your upper right corner and the chat function is disabled today. Let's take a moment to talk about public comment, which is going to be at 3:40 p.m. today. We're going to be calling on you in the order in which you signed up, and I will let you know that we've had 41 people sign up for public comment. Because there's a 20-minute public comment period, I can say with pretty strong certainty we're not going to be able to get through everyone on the list today. That said, as a reminder, there are other ways to provide a public comment, and all of the public comments do go to the work group do go to the work group, and they will be able to review those public comments. So please know we are not prioritizing spoken comments over written ones. And the way to make public comments, you can go to that HCA Universal Healthcare website, and there's links for you to make your public comments. Let me see if I have any more information for you. Oh, one final note I want to make about public comment too. We do anticipate, especially as we're really getting into the meat of this work, that there's going to be interest in making public comment at different points in the meeting, not necessarily at the end. And so we are looking at how we might restructure timing of public comment at future meetings. If we do any of that, we'll make sure that you've been notified about it ahead of time so you can plan accordingly. But we do recognize that there may be times when you'll want the work group to deliberate on your public comments prior to the meeting. So we may shift the timing of the public comment. So I'm going to stop sharing for a moment and look at everyone here. Let's see. Oh, I saw one quick hand raised. Kelly, did you have a question about?
Public comment?
Yes.
Yes. So we could have 13 people speak for 1.5 minutes during that time. So I'm wondering, it just seems like it's so important. And could we, as a body, decide to extend the public comment period?
I think
And
we're
maybe even make it 1 minute or something like that. Or maybe some of those people would skip, would relinquish their time. I don't know, just, it's a lot for people to cover.
Sure. Yeah, and that's actually, I think, getting back to my point about how we might need to revise our public comment approach at the subsequent meetings. I think we can consider making some changes to the timing or length of the individual comments. I should have mentioned comments are going to be 2 minutes today, and we'll be strictly enforcing that timeline so we can get as many people as possible in. Kelly, to answer your question about what to do today, because we've communicated about the public comments and the approach today, I'm not comfortable changing it for today, but we can talk about how we might do it for future meetings. And again, a reminder.
Because that's 10 people. We can only hear from 10 out of those 41 people today.
Yeah, that's right. As a reminder though, folks can contribute public comments written and our work group members will see those. So please do, if you don't get called on today, please do share your public comments. So now can I ask members of our public to turn your video cameras off? Thank you. I appreciate that. All right, and we have our fearless leader here. So I'm going to turn it over to Sue Birch, our chair, to do a brief welcome to all of you. And I'm clicking on the ask to unmute button there. There we go. Take it away, Sue.
I think you've got me now. Am I unmuted?
You're unmuted. You're good.
Great. Hello, everybody. It is great to see everybody's face, although it is like 8 screens of faces. Kelly, to your point, there's a lot of us, but we will move quickly today. I am really pleased that we are having this meeting again, and I want to just really acknowledge it, whether you're our service delivery partners, whether you are primary care providers, whether you're our public health folks, health benefit exchange partners, community agencies, elected officials. It is great that we are all getting through COVID and doing what we need to do, but still paying attention to this very important issue. So I want to just really express my gratitude and thanks to all of you for continuing to be flexible, tenacious, patient, and dedicated. We really have no time to waste. So thank you, and I really appreciate that people are juggling a lot and making it work. And in Michelle Obama's words, it is what it is, and we will just keep doing our best. And we'll give a lot of compassion and understanding. And thank you, HMA and the HCA team members that keep this absolutely marching on. So for many, the pandemic has really illuminated the devastating inadequacies of and the inequities in our healthcare system. On top of that, the widespread protests for racial justice sparked by the recent murders of George Floyd and Breonna Taylor have caused many more people to stand up and say, enough. I can't tell you how many people have said to me how absolutely awoke they have become on a variety of issues. So now more than ever, our work to advance universal healthcare is really essential and urgent. It's my understanding that the project team is working to create space and background materials for a more focused discussion on how the recommendations of this work group might impact issues of health equity, and I really support these efforts now more than ever. The legislature recognized that a transition to a universal healthcare system in Washington would be fraught with challenges. They have asked us to help them identify a path forward, informed by all the stakeholders who would be affected by this transition. While consensus may not be a realistic goal, it is our charge to work together to understand all sides of the issue and share these perspectives with policymakers. I see our work group members taking the time to review materials in advance, contributing their ideas thoughtfully in work group discussions, and listening to each other. I cannot thank you enough at this time in our country's history for having and engaging in civil discourse. We don't always agree, but we respectfully disagree. You may not agree with everything and all of these points, but you really continue to engage in that meaningful dialogue, and that will help us secure a more just and effective healthcare system and a more healthy and equitable society. So again, as I said earlier, I really want to extend my gratitude to each of you for your time and your commitment to this very important work. Jamie, I'm going to hand it back to you to keep us moving right along so we can keep opening up as much space for comments and participation.
Thank you so much. Thank you so much, Sue. Appreciate it. I'm going to take a moment to review our agenda. So I'm going to share the screen again here. So a reminder of our meeting objectives today. We are going to hear an update on the actuarial analyses and provide final input on 2 key questions that we need to answer to finish the actuarial analyses, specifically provider reimbursement and cost sharing. Then we're going to begin the process of assessing the 3 models of healthcare using the qualitative or policy level assessment criteria that were informed by your deliberations at the February, which now seems like a million years ago, February 2020 meeting. Then, of course, as always, we'll confirm action items and next steps and move to public comment on universal healthcare. So quick, just run through of exactly what we're doing when we've already done the technology review and welcome, and I'm in the process of reviewing the agenda. We're going to do that first set of breakout groups covering cost sharing and provider reimbursement. We're going to do that in 2 20-minute blocks. So all of our work group members will get to deliberate on both cost sharing and provider reimbursement. You're just going to be doing it in different order. As with our last meeting, we're going to have one breakout group happening in the main room where all of our members of the public are going to be, and the other breakout group will be happening in a separate room. And the facilitators are going to switch back and forth. So you won't need to do anything. You'll just be automatically sent to where you need to go until those deliberations are done. And if you're in the breakout room, then you'll get a little notification telling you to click a button and come back to the main room. Members of the public, you'll be able to watch live the deliberations in the main room. They're also being recorded by TVW and shown, I think, simultaneously. We are going to be recording the breakout discussions and posting those videos to the website. So you will be able to review the deliberations that happen in the breakout rooms. You just won't be able to watch them today. We're going to come back together at 2:05 p.m. to do a report out on what we heard regarding cost sharing and provider reimbursement. And then at 2:30, we're going to get a stretch break for 10 minutes. At 2:40, we're going to come back together, and I'm going to send you off to your next set of breakout groups where we're going to discuss the qualitative criteria and begin thinking about how each of the 3 models might facilitate achieving those desired outcomes that you've articulated. We'll do that for 40 minutes, and you'll just stay in, we'll be in 3 different breakout rooms, 1 main room and 2 breakout rooms, and you'll stay there the whole time. There won't be any switching of facilitators. We'll all come back together in the main room at 3:20 p.m. to do a 15-minute report out. And then at 3:35, we'll run through action items and next steps and go into the public comment period at 3:40. And we'll have the 20-minute public comment period and adjourn at 4 p.m. I'm going to pause there. I see Aaron Katz has raised his hand. Let's see if one of my team members can help me unmute Aaron. That would be great.
Great. Thank you. So first, Sue, I want to thank you for your opening comments and placing this discussion in the context of COVID and Black Lives Matter. I think that was really important. Two questions. One sort of one related to that, and the governor has 3 advisory groups that are helping him think through the state's response to the pandemic. And I'm just wondering, it seems like there's an important connection between the work of this work group and those advisory groups. So I'm wondering whether either HCA or the consultant team has had any connections with or communication with those advisory groups. So that's one question. The second question is really about the process that we're going to be going through today. And I think at least one other work group member sent in some concerns that the discussion seemed to be framed as our individual perceptions of these criteria in relationship to the models, and that there's a significant amount of empirical work that's been done. There's a lot of good information to inform that discussion. And so far, I haven't seen any evidence of that work. And I don't really think it's useful for 34 work group members to say, well, I think this, I think that, I think this. So as I said in my comments, I hope that this is going to be an evidence-informed discussion. So I'd like to know, what's been done to bring the best evidence to the discussion. Thanks.
So Aaron, I think I'll answer your second question, but I'd like to pause and see if our project team, if anyone from our project team wants to answer the first question about the different advisory groups, or if that's something we need to return back to the work group with a response to. So is there any, I see Sue raising her hand. Let me unmute Sue here.
I think I'm unmuted.
You are.
Aaron, thank you for that question. And yes, the 3 times a week, the Uniform Command Group meets, as well as many, many other cabinet and sub-cabinet meetings where things are braided together. Those 3 teams that the governor has on COVID are so granular in PPE and hospital transportation plans and remdesivir that they don't take shape in those conversations, but at a higher level. So as we continue our work and as we keep dealing with the unexpected twists and turns of the pandemic, we look at every opportunity about how our work either conjoins or braids and blends in, or it doesn't. And we are doing some scenario planning about November, depending on which administrations at both state and national level. So to the extent that we can braid these conversations in, we are, when it is appropriate. So we're very involved at the Uniform Command level and at the cabinet level, and we are sharing this information as it's appropriate.
Thanks. I just maybe this is for your information. Some members of some of those advisory groups have been thinking about and have talked with folks involved in this process. So there may be an opening to cross-fertilize.
Jamie, I'm unmuted, aren't I?
You are, yes, Liz.
Sure. It's not the same work group, but there was a question that came in about the relationship between this work group and another work group that's being convened by the Health Benefits Exchange, of which there's a lot of crossover. And we are in connection with them, and we're preparing something so that a presentation at some point to talk about that intersection in a pre-record in the future to see how this would play out. So I also want to just acknowledge that, even though it's not the exact question that you asked.
And Aaron, as promised, I'll go ahead and attempt to respond to your second point. In fact, our project team got together yesterday to discuss. We heard from you, and from Kelly, concerns about wanting to make sure that ultimately we were having an evidence-based discussion about the qualitative criteria and its relationship to the different models. So we were actually planning on sharing this when we got into that breakout discussion, but I think it's probably just worth putting out there now. The purpose of today's discussion is to begin the process of taking the criteria you developed in February at the work group meeting, which articulate, as you know, the priorities such as access, equity, and quality, and assessing which, if any, of these models are capable of delivering these priorities. And for many of these criteria, you may not have an answer to this question because you may determine that it really depends entirely on how the model is implemented rather than which model it is. We consider that to be valuable input as well because the legislature is looking to this group to recommend not just a model for universal healthcare, but also key priorities when implementing that model. But I do want to mention, and this is something in particular that Shane emphasized to me, it was helpful to hear. It's important to note that the actual implementation of a universal healthcare model will require a level of specificity and expertise beyond the scope of this particular work group, specifically developing policies, rules, and regulations regarding every aspect of the plan and program. And that level of program design will ultimately determine how equitable, efficient, and effective the model is. But what we're looking to this work group to do is to articulate the desired outcomes of a universal healthcare system, provide insight based on your individual lived and professional experiences and expertise as to whether each model is capable of achieving those desired outcomes, and of course help shape the structure of the universal healthcare models, all the while recognizing that how well each model actually achieves those desired outcomes you've articulated will really be determined by the operational and implementation decisions of the state down the road. So again, some of you have raised concerns about conducting the qualitative assessment based on personal opinions and impressions. And this actually brought up an important concern, illuminating a tension that we've been navigating the work group and the project team from the beginning, which is how we appropriately balance your individual perspectives with the best available data and research. Unlike the quantitative criteria for which you're going to have data from the actuarial models in September, the data and information available to support the 34 separate qualitative criteria that you articulated at the February work group meeting, I understand from our experts that really varies in quality, relevance, and availability. We've got some really good resources from a number of you, and then for some of the criteria, maybe there's not as many options. That said, I want to emphasize that the legislature was intentional in convening individuals from a wide range of lived and professional experiences and expertise for this work group, and your perspectives from those lived and professional experiences are really important and relevant to this discussion in the legislature. So just to reassure, particularly the people that raised these concerns, this is the first of multiple discussions. We'll be continuing the discussions about qualitative criteria, desired outcomes, and implementation at our September and October meetings. And as we've done with the June and August meetings, we will be looking to provide you with pre-recorded presentations and information briefs on specific topics. So one of the things we'll want to surface today is where of these 34 separate criteria you'd like to do a deeper dive. And if the information is relevant and of quality, we can put together some more in-depth topics there, or pre-recordings. For example, as mentioned earlier, we are preparing to provide a presentation on health disparities prior to the September meeting. So that's kind of the big picture answer, Aaron, to your question, or at least to try to address your concern. But I do want to emphasize that we do take the concerns that you raised very seriously and want to use this as a stepping stone to building toward evidence-based discussions around qualitative criteria. Aaron, I see you're unmuted there.
Well, I'm hesitating because I'm not sure I want to chew up too much of the work group's time, but with respect, Jamie, I don't find that response very adequate. Just let me give you an example. As you know, I staffed a process like this of stakeholders for 2 years. So I appreciate the various
Oh, no.
that group of different
You
perspectives.
got, Aaron, you got muted there for a second. Can you just back up like 30 seconds to where you were?
Well, just to say, there's no contradiction between a stakeholder group, as this work group is, with a wide range of perspectives, and informing their discussion with very good information. Let me just give you one example of the criteria that we're going to be talking about here. Reduces administrative costs. Now, there's very good information out there about the administrative costs of single payer systems, multi-payer, universal systems, and our current system, right? So it seems to me that the outcome of our discussions is going to be much better, much more solid, and is going to be a stronger basis for recommendations to the legislature if our discussion is informed by that information, rather than me saying, well, you know, government systems are inefficient and, you know, they're just inherent, and so administrative costs in a single payer system is going to be too high. I mean, so I just think that having these discussions without that level of information is kind of spinning our wheels.
I want to make sure you were able to finish what you were saying, Aaron, before yeah, you're good. Okay. I think again, I appreciate the thinking there and the feedback. I see another hand raised from Kelly, and I do want to make sure we to get back on our agenda. So I'm hoping we can wrap this conversation up now and move into our breakout discussion, and then maybe we can revisit this when we're in our breakout rooms. Aaron, I want to assure you that our group hears you on this. Our intent for today, and we've staffed the breakout groups with subject matter experts who can hopefully, and we're intending to shed some light on things like administrative costs, if those are pieces that are coming up for discussion. But I also want to assure you that we will take this feedback from you and Kelly and others and discuss it further about how we can advance these discussions at our September and October meetings. I see that Kelly raised her hand, and then Bevan. And again, I'd really like to make sure we have time to cover all of our agenda today. So I'm hoping we can wrap this discussion. I see Kelly nodding. Kelly, go ahead.
I just want to say one thing that would make me feel a lot better about it is if we added in the key, if we added number 4, not enough data, need to circle back.
Yes.
So as a group, we could say that I can't address criteria right now. Would that be possible?
We lost you for a second. Yes, Kelly, actually Liz and I discussed that with Liz this morning, and we thought that that was a really good problem solving suggestion. I do want to reiterate, as I understand from our subject matter experts, again, some of the research and information, it varies in quality, accessibility, or availability and relevance, but I think we can start by indicating where we would need more information to deliberate and then go from there. So
That'd be great. Thank you.
Okay, thank you. Bevan, I saw you had your hand up. I don't see Bevan though. Bevan, can you turn on your video camera? Is that possible? Let me see if I can find you here. Oh, there we go. Okay, I'm gonna unmute you. Thank you. Just bear with us a second. I'm gonna unmute you here. There you go.
Cool. Can you hear me? Okay. I'm going to make this super brief. I just was going to say this might be a really good opportunity to bring some more material up in a, final meeting that I'm hoping we could have in December. And I think I sent an email out to everybody. I hope everybody was able to see that, but I would love to maybe at the end of this meeting just kind of have a quick little what are next steps and maybe talk about an additional meeting, because I really do think this is critical to make sure that we're not rushing this conversation, especially in light of what to kind of put out on the table at the beginning of this meeting. So,
Bevan, you actually gave me a perfect
pivot.
Yeah, you gave me a perfect segue to my next slide, which is about going back to the work process. So let me take you there. Okay. So as with every meeting, and I'm going to make this really snappy since you've seen these slides before, and I want to make sure we have time to do justice to these discussions today. So I'm going to skip what we've done September through June, since I know you know this, and just remind you where we are today. We just talked about this, about assessing the models of healthcare using qualitative criteria and doing a deeper dive into some of the questions we need to answer for the actuarial analysis. You saw we added a November meeting. When we're looking ahead to September, October, and November, and in response to Bevan's feedback, and also just our own deliberations about how best to proceed, also Kelly's feedback about wanting to understand the timing of developing the report and providing feedback, let's consider what we have up here. There's one more screen here in November, a living document. We're actually looking at some options for how we might add another meeting or expand our deliberations prior to developing the report, because that's when you're going to be really getting into the meat of your discussions around both your recommendations based on the outcomes of your assessments, as well as what items still need to have attention and the recommendations for how to address them. And then finally, near-term transitions and other strategies for moving universal healthcare forward. So I would say right now, we have not had the in-depth discussion of our recommendations with HCA yet, which is why I can't provide you specific details today. But please expect to hear from us about how we might recommend adjusting the schedule in the coming months so that we can really do justice to your deliberations and get through the meat of your agreements before we develop the report and send it out to you for review. So right now, what I've got here for September is we're going to review the actuarial analyses in September and also continue our discussions about the qualitative criteria and policies. Then, as I said, the plan in October currently is
Jamie, we can't hear you.
to develop your recommendations.
Oh,
And then,
you cut out for a second, Jamie.
oh, I'm sorry.
It's okay.
Can you hear now?
September. Yeah,
Okay.
you're back.
I'm back. Okay. So again, this is a living document. We're looking at making some adjustments, and we'll get back to you very shortly once we have confirmation on that. Liz, do you have anything to add there?
Oh, no, I mean, I guess I'd just add, you know, what I said earlier, that we realize that things are evolving. And I mean, I will just say that I think that one of the challenges that we've faced over the last few months is that there's often been a big gap between our meetings. And so it's hard to get any momentum going and to remember, what did we talk about last time? I think part of the hope today with bringing this qualitative assessment criteria back is that it was back from in February. And we're going to talk about it now, but we're going to be coming back to it again. But it's been a while since we've done all that work about understanding where we want to go. So I think we're hoping that as we get into this fall, we'll have, you know, a lot more time focused together, you know, in a more seamless fashion, so we can, you know, finish this up strong. So that's our hope.
Thanks everyone for your patience as we got through our opening remarks and agenda, and also discussed the feedback from our workgroup members. I appreciate that. We're a little behind schedule, but I'm confident we can catch up and make sure we preserve our public comment time at the end. So let's go ahead. We're going to move into our breakout sessions. As I mentioned earlier, we're going to be discussing cost sharing and provider reimbursement, and everyone's going to get to cover both topics. But some of you are going to be moved right now into a breakout room. So you should get a pop-up momentarily from Liz, from New York Liz. So please look out for that, and we'll get started with our breakout discussions. Take it away, Liz. All right. Let's see. I'm just going to make sure we have our right team in here. I do. I see Jared and Nora. Awesome. Okay. Hi, everyone. So this is cost sharing. We're going to be talking about cost sharing here. And the purpose of this discussion is to get final input from you on how we approach cost sharing in the actuarial models. So as I said before, each breakout, you're going to get to discuss provider reimbursement too. So we'll use this 20-minute period to focus on cost sharing. For this discussion, we really want to understand your philosophy around cost sharing. So we're not asking you to provide specifics on income thresholds or anything like that. It's more about if you see cost sharing as a valuable tool, or if you have serious concerns about cost sharing being a barrier to achieving care or any of those things. You should have reviewed the pre-recorded presentation and gotten up to speed on cost sharing. And hopefully you also have that multi-page handout that we provided to you as background. Oh, Shane, I think you're supposed to be in the other room, right? Hey, Liz, can you send Shane to the other breakout room? I'm sure they're desperate for him. Sorry, I'll keep going, Shane. Hopefully you'll get moved there. Finally, based on feedback we received from workgroup members at the June meeting, we are assuming that premiums would not be charged for the two universal healthcare models, options A and B. Rather, to achieve universal healthcare, we're assuming that everyone will participate without having to pay a premium. So we're not going to be discussing premiums. That's already an assumption baked into the model. I'm going to ask a question in a moment, but I see Dr. Weinberg has her hand up. So Dr. Weinberg, you wanna, I just unmuted you, so you should be able to go.
Cost sharing has not been shown to influence significantly the use of necessary versus unnecessary care. As a physician, I can tell really easily what ought to be taken care of and what ought not to, but the general public has no idea. And they make their decisions about where they're going to go based on fear, based on what their neighbors say. And sometimes they are afraid to go because of cost sharing, and that can be quite detrimental. The administration of cost sharing generally costs more than you collect from the cost sharing if you keep it low. And of course, if you keep it high, then that means only the rich get medical care and everybody else is scared out of the system. I think we should go for zero cost sharing beyond paying the premium or whatever contribution everybody in Washington State makes into the system to provide the care, which is free at the point of service. Thank you.
Okay, thank you, Dr. Weinberg. You actually kicked off my first question. I was going to do a round robin saying, based on what you know from the presentation and your lived and professional experiences, where do you stand on cost sharing? So I hear you that your observations is that cost sharing does not serve to prevent unnecessary care and in fact serves as a barrier. And you would like to see the models incorporate no cost sharing for anyone. I'm gonna-
It also raises administrative costs.
And raises, thank you for reminding me of that, yes, and serves to raise administrative costs and complicate things from your observation. I'm gonna ask others what your reaction is, having reviewed the materials and also based on what you've observed in your professional and personal experiences. Are there other reactions around whether you think cost sharing should be in the model or not, and why? Okay.
Yes, I have some, can you hear me?
Yes.
I have some experience in that. When we proposed the legislation back in the 90s, Group Health had said that by adding a $10 copay, that it would end up reducing the attendance or the visits of people that are just going for social reasons. And a variety of other things that showed that that was what it contributed to. I'm not sure that's has any evidence other than just anecdotal. And so I think what we do need to have is some kind of experience that would show whether or not that kind of experience is true. Otherwise, we're just guessing.
Okay, so Dennis, it sounds like you've observed that there may be some opportunity for minimal cost sharing to reduce unnecessary care, but you're looking for more evidence around whether that is true. I'm going to pause before I call on some of our other folks to raise their hands and see if our subject matter experts, either Jared or Nora, have any evidence to share on that. Jared?
Jamie, this is Jared. I can go ahead and share just a couple elements. I'm not saying these are groundbreaking studies, but to, I guess, kind of respond to your comment around whether there has been research. Our understanding, there's an abundance of research that says cost sharing hurts access to care. There is some out there, I think in the New England Journal of Medicine, related to ER copayments. And then there was a second one, I think it was, we'd have to get you the reference here, I don't have it in front of me. It was in the American Journal of Public Health that talked about cost sharing and its influence on provider office visits. But again, those are kind of in the minority. They're small number of studies relative to the opposite.
Let's see. No, go ahead.
Additional background, going back to the really seminal study done by the RAND Corporation in the 70s, they looked at cost sharing, and they did see an impact, and certainly impact is more notable for lower income folks than for people with higher income. That doesn't get at, sorry?
I interrupted you.
I was going to say that work was really just focused on whether there was impact. It doesn't get at kind of the more nuanced conversation about whether that's a good thing or a bad thing.
Okay, so just to clarify then, the RAND study found that for particularly low income folks, sharing impacted whether or not they sought care, but they didn't say whether it was positive or negative. Okay.
Right, and a lot of the flows from that has come out of that study, sort of built on the study.
Okay. Ronnie, I see your hand followed by Bevan and then Jane. Ronnie?
So my experience in pharmacy is that these, co-payments at the point of service really does create an inequity. People that can afford $1 are very likely not to purchase an item that has a $5 copayment if they have 10 items to purchase. It's just been a clear line of demarcation. And I think the literature does show that copayments do create inequities. People don't understand it, and people don't want to owe you something. They want to pay, and they will not pick up prescriptions, and that's difficult enough for chronic diseases that don't have symptoms like high blood pressure. It's difficult enough for the patients to balance those issues. So I believe strongly that we create major barriers when we add co-payments.
Okay. So I'm hearing a lot of concern about co-payments and creating major barriers. I'll be curious to know if anyone, Dennis sort of mentioned some possible observations of some merit to reducing unnecessary care, but I'm going to be curious so we can provide some direction to our Optimi about whether it sounds like we're leaning toward not including cost sharing. Bevan, you're next.
Well, I guess, really my echo is with everyone here. I think also just from, kind of a policy standpoint and the political fervor out in the world is, we're already forking out, some people are forking out thousands of dollars every month for their premiums to begin with, and then having to go in and be responsible for a copay on top of that is just feels morally wrong. And, you know, it's also backed up, it looks like, by a lot of research. So all the research that I've seen is that it very much, you know, builds barriers to care. It doesn't incentivize people to, you know, access their primary care, dental care, any care that people need in order to be able to really be a healthy human being. If there are costs there associated with walking in the door, most likely they're not going to do it, especially if they're having to pay every month for a plan.
There was one thing I forgot to note I should have mentioned, which is my understanding from our actuaries is that regardless of what we chose for cost sharing, and it sounds like folks are leaning toward not including cost sharing in the model, but regardless of what we chose, the very lowest income people, those who are eligible for Medicaid, would be shielded generally from cost sharing because that would be required for compliance with federal rules. Jared, give me a thumbs up if I have that right, or if I thumbs down if I got that wrong.
Yeah.
Jane,
Yeah, you got that right. And
oh, sorry, I'm sorry.
if I could, I guess maybe try to add to some of the discussion a little bit, just to reiterate. I think some of the discussion around the cost sharing came up as an offshoot from the discussion comments during the last work group meeting. There was, I didn't tally it up, but there were some folks that were genuinely interested in seeing some co-payment. They weren't really necessarily excited about a deductible or a co-insurance circumstance, but they seemed to be suggesting a co-payment. I do, just in listening to some of the comments coming back, just for context, because I wanted to try to fill in some blanks, maybe based on some of the comments we heard in the opening. Just to put, I guess, the cost sharing in context, as it stands today, there's about, or approximately, this is per a KFF study, of covered workers in the United States, about 82% of them currently carry some sort of deductible, co-insurance, or co-payment with their coverage. And it certainly varies whether it's uniform or not. So to some degree, I guess as you think about the question, if this changes your perspective or not, I'm just throwing this out there for food for thought. But there 80, you know, we're talking about 80+% of folks have this kind of cost sharing now, and more or less, I think what we're asking with the question is, do those deductibles and co-insurance go away in place of a nominal co-payment that is a little more transparent in terms of pricing, whereas maybe the deductibles and the co-insurance would not be transparent because you don't know what the negotiated rate is. I don't know if that changes folks' perspective, but I'll shut up now and let you all continue your conversation. But I did want to kind of throw that out there.
Great, thank you. And I see a lot of hands up, and we have probably limited time here, so I want to make sure we get to everyone. So Jane, you were next.
Thanks. So following up a little bit, Jared, on what you said, what I'm really struggling with is there is also literature out there done by the Washington Health Alliance, done by Milliman, about overutilization of services and taking risks of things like back surgery when the back surgery potentially has more risks than the benefit that it can yield. And so the thing that I'm worried about is having this discussion about cost sharing without having the discussion about reimbursement, without having discussion about whether we're going to be changing sort of how providers and hospitals operate their businesses. So providers that own advanced imaging equipment have an incentive to use the advanced imaging equipment. So I guess what I would say is I completely agree with Jared about the unpredictability of coinsurance. But the question is whether there's a way to use co-pays to disincentivize use of brand name drugs when there's a generic available, or to have more appropriate use of those kinds of low value services like advanced imaging that Milliman and others have done research on.
Okay, Jen, so I'm hearing you say, not necessarily contradicting what others have said about not wanting to discourage necessary care or people seeing providers, but that I'm hearing you say there may be opportunities to use co-pays to discourage low value care. We've got 5 minutes and I've got a number of people who haven't gotten to speak yet. So, and I see Carrie Mckenzie raising your hand. I'm gonna take you in the order I saw your hands go up. So I saw it was Vicky, then Dr. Dietering, then Carrie Glover, and then Carrie Mckenzie. So Vicky, I'm gonna unmute you. And because we have 5 minutes, I'm gonna ask everyone to try to keep your comments pretty brief if possible.
Thank you. I think I said this last time, but in the Indian healthcare delivery system, we don't utilize copays in care. And I don't think that that makes us see people overutilizing services. Although I do agree with what Jane said about some of those services that the providers want to provide. But I do think if people are needing services, sometimes they do go to the ER, and if we could focus more on care rather than money, we would probably see those costs go down as well.
Thank you, Vicki. Okay, then Carrie, I think it was Carrie Glover next. So Carrie, I'm gonna unmute you.
Can you hear me?
Yes.
Okay. I won't beleaguer a lot because I think Jane said actually a lot of what I've been thinking about. I mean, so I represent a lot of chronic disease organizations, and one specifically is the Bleeding Disorder Foundation. So when you look at someone with hemophilia, the predictability and cost is really critical. And these people, these patients face really high exorbitant costs. And so I think that gets at like the coinsurance versus copay. Copay is much more predictable, and we've done a lot of work on standard benefit design to try and shift that because that makes it more manageable. So Jane said a lot of that. I won't dwell on it too long. I think other thing that we looked at with the deductibles, and again, we've had these conversations a lot, is deductibles with people with chronic disease that have these high costs. They have to be prepared to pay that entire deductible in the first month of the year. Like, and when you have 2 kids with hemophilia, that you're hitting your out-of-pocket max that first month of the year, that like a lot of families don't have the privilege to be able to carry those costs. So if you're looking at copay, how do you make sure that for families like that, that cost is borne throughout the year? Like if you are going to include some kind of cost sharing, that it's borne throughout the year, that they're not being faced with a $6,000 bill per kid. So like some of our families, like 2 kids have hemophilia, and then they have a $12,000 bill in January. And that just is really, really difficult for a lot of families to carry. And so if you are going to have some kind of cost sharing, if you're going to do copay, I really would discourage coinsurance, but if you're going to do something, how do you make sure that that's carried throughout the year so that families can carry that, because it can be really, really a big barrier to them accessing coverage and care.
So I've heard 2 important, and I'm so sorry to rush you here, Carrie.
No.
2 important points that I've heard echoed from others. One is whatever cost sharing, if we do go with cost sharing, to reduce unnecessary care, that it's transparent. And then also I heard, this is more, it sounds like more of a policy level thought of how it's structured so that families aren't hit with a big bill up front. Okay, Doctor, we've got 2 minutes. So I'm gonna ask Dr. Dietering to speak, and then Carrie Mckenzie, and then I think we're gonna be out of time. Dr. Dietering, there we go.
Yeah. So I guess that I want to echo what a lot of people have said. There is really strange and irrational behavior that happens when it comes to healthcare with high deductibles and coinsurance and things like that, from what people have already talked about. But you know, it's November, people have already paid their deductible, so they want their surgery before this year starts over again. So there's all kinds of things that are incentivized behavior that isn't very appropriate, that is incentivized. I definitely see patients who don't want to come into the office who have a high copay, or excuse me, a high deductible. However, I do believe a small copay as a little bit of a speed bump that for people to think a little bit about, do they actually need to come in and get care? We see in care that is totally free a much higher utilization, and we can say that that's good, but we also know we have a limited supply of clinicians, and if suddenly there's no small forethought to accessing those clinicians, we'll have even a greater access problem in my mind than we do now if there's no even small hiccup to going in. And I think that not for the people who are very, very low income, but for other folks. So I think a small copay is in some ways a good thing.
And last but not least, Carrie Mckenzie. Get you out there.
Yeah, I got it. Great. I love this conversation because the predictability of costs I want to echo, because it's so figuring out how to pay every month and then figuring out how to do the balloon payment when something actually happens is just unaffordable. I also want to echo that I've heard from a lot of people that people keep thinking that these copays and deductibles and that impact low income. They want me to tell you specifically, all of my neighbors, everyone, that it's now encroaching upon the people making $100,000 a year as a very distinct thing and a big part of their budget, no matter what. And so they're asking that you don't think about it as just low income. It is about how do I afford this? How do I pay $12,000 a year in premium and then a $6,000 deductible? I don't know how to do that every year. I don't know how to make that happen. And then we think about that. I mean, what other product in the world do we pay $12,000 for premiums, and then you have to pay $6,000 more in order to actually use the system? So it doesn't follow even just a normal logical thing of I paid $12,000 for 10 years in premiums, and the first time I want to use it, I now have to pay up to $6,000 in deductible. So I think we just need to bring some logic back to if I were providing this as a service and I don't want any for-profit in this, but it also needs to make sense to people. It needs to say, I paid all this money, I need some insurance, and I don't really get it because the co-insurance and the deductible basically make holes in the kind of support that you thought you were buying into.
Okay, well, I think I'm about to get moved, so I just want to say a quick summary. In fact, I'll have to move in a moment. Sounds like, Jared, we've got some predictably mixed reviews on using cost sharing. I think those folks that have articulated an interest in considering cost sharing in the model have expressed that they're really leaning more toward copay, and we need to steer away from less predictable, less transparent ones. And then there are a number of people in the room who have very strong feelings about the impacts of cost sharing on usage and would like to see an entirely cost sharing free model. So thank you. I'm sorry that the discussion was so short. I feel like we could have taken another 20 minutes easily, but now you get to talk about provider reimbursement. So here we go. Bye.
Are we ready? Great, okay. Hi, everyone.
Did Shane make it back in here?
He should have. He was coming with me. So Shane and Janine, are they both back?
Janine's there.
Okay, great. We did not have enough time in the last breakout to adequately address these questions related to provider and reimbursement. So I'm going to try to be quicker with my introduction. Just to say hello, we're focused on provider reimbursement here. I'm your facilitator. We have Shane and Janine to speak to you as subject matter experts. This discussion is really about getting an understanding of your overall philosophy around provider reimbursement. Questions are aimed at understanding what you think is the right balance between controlling system-wide costs, compensating providers, and ensuring access to needed care. I'm going to stop with the rest of the preamble and hand it over to Shane to tee up the first question for discussion. That worked well for us in the last breakout and will give us more time to chat. So Shane, would you, and Rochelle, if you wouldn't mind helping me as hands are raised, helping me with that facilitation. Thank you.
There's Shane.
Oh, Shane's here.
Betsy's ready for you to talk, Shane.
Great. So
Shane, I teed up the question. I just want to go right to the questions because I think I overtalked last time. So yeah.
that works. So the first question is about whether or not we should attempt to capture some of the administrative savings that providers might experience as a result of transitioning to a more streamlined single payer system. This is particularly relevant for the modeling because even small changes in aggregate reimbursement translate into massive amounts of expenditure when looking at a model this large. So just to illustrate that, a 1% change could be as much as $700 million worth of expenditure for the state. So what I would note is that there is a body of literature that talks about the differences in administrative burden for providers. The example that we discussed in the last group was there was a study comparing the administrative burden on providers in Ontario, Canada to average expenditures in the United States, and it found that there was a 400% difference in administrative investment. However, if you look at what drives the differences, you note that it's things such as prior authorizations and not necessarily just having a more streamlined system such as single payer. I think that kind of universally we recognize that having to deal with fewer payers is likely to reduce administrative burden, but there is some ambiguity in terms of how we would quantify that. And given that the magnitude is potentially so impactful, getting it wrong is a problem. So we're really looking for your insight and your boots on the ground perspective in terms of whether you think it's appropriate for us to try and capture some of the efficiencies that providers may experience. And two, if you have insight in terms of how much we should be attempting to capture given that the body of evidence around it is somewhat ambiguous.
Rochelle, you're on mute for some reason.
Can you hear me now?
Yep.
Okay. So sorry about that. It looks like Dr. Weinberg has got her hands up. Give me just 1 second so I can unmute yet.
Hi. I was a solo practice pediatrician, a vanishing breed, and I'm vanishing. I've been retired for over a decade. But right before I retired, the billing service that I had to hire because I could not handle billing all these insurance companies in-house in a solo practice, they went from 8% of my gross income to, they were going to go to 10%. And I said, that's the last straw as I retired. So it's a significant amount of administrative hassle. And as for having to do all the prior authorizations and all of that, that is also tied to having multiple insurers out there who all delight in having different criteria all done by people without medical degrees. And if you have one system, then you will have one set of criteria for when you can do what kinds of fancy things, like when you want to use your fancy imaging machine that you've overpaid for in order to pay it back. There will be criteria. We can set criteria of what is appropriate and what isn't. The other thing is important that we're using the word provider. Providers are all over the place. They range from mega hospitals that own everything under the sun to small practices. And the effects of all of this system are different and need to be taken into account to try to get a whole handle on the enormous expenses and income, even bigger, in hospitals. We're going to need to use some kind of global budgeting system to get control of that. But smaller physicians' offices and the like are going to need to be handled differently. All right, I've said enough.
Could I summarize the main points from that real quick to make sure I captured it accurately? So it is a real phenomenon and something we should be considering for modeling. I'm making that extra step for you if that's okay. Tell me. Okay, fair enough. There's significant variation in provider and provider type, and that warrants differential treatment as appropriate. And then lastly, how you pay matters. It's not just the magnitude of
That'll do.
Okay.
That's a good summary.
Right, and next up we have Vicky Lowe. Oh, let me see.
I got it?
Yep, there
Hi.
we go, thanks.
Hi, thank you. This might be further down the road, but has there been much talk about cost-based payments, especially for smaller providers or in rural areas, as in the way that federally qualified health centers are paid, where they do a cost analysis and maybe adjust it annually or quarterly, and that would include the cost of the of administration and the referrals and those types of things.
And that topic actually was raised, I believe it was in was it March? It was pre-COVID. However,
February.
February, thank you. We did talk about that just briefly. I know that some of the work group members did raise the concern that the FQHCs go through a very robust cost reporting and auditing process to get to those cost-based rates, and that it may not be feasible to do that on a much broader scale. So that's just kind of refreshing what I heard from prior conversations, but I'll certainly note that if I'm pulling away the core concept here is that you believe that for small providers, it could be advantageous to have a system design that factored in costs. Is that a fair summary? Okay.
Do we have other hands raised? Before we have one other question to consider, and I don't want to shortchange it like we did the last meeting.
Go there, we don't have any other hands raised.
Okay, great. So Shane, let's go to the second question. If you would summarize that and tee it up.
Sure thing. So the next question is really about purchasing power. And what I want to get at is whether or not it's realistic to leverage that purchasing power to bring down compensation or cost for the plan in Washington. So you can think of that in terms of if you have a single purchaser, they have much more influence over how much they're willing to pay to both providers, perhaps drug manufacturers. But what we don't really have a clear understanding of as we're approaching modeling is the political viability of doing that, and essentially where there's opportunity in the delivery system to take advantage of that. So for example, are there large monopolies where with hospital providers, for example, that are driving pricing up, and that's something that we should factor into the model. Conversely, are there services such as primary care that we recognize we need to bolster under a single payer model? So the underlying question is really trying to tap into your Washington perspective and your diverse experience and help us identify where we should focus our efforts in terms of making specific adjustments in the model to increase or decrease reimbursement and potentially leveraging that purchasing power that we would have under a single payer model.
All right, Jane Beyer.
So Shane, the only thing that I would say on that one is your point about market consolidation is a legitimate one. And so in any modeling that you do, I would suggest that you look at the FTC data around, I can't remember what the name of the score is, the something Hirschenfeld score, for the various MSAs around Washington State, to just get a sense of how realistic an assumption around purchasing power would be in highly concentrated markets where you've got one dominant system.
Okay, thank you for that, Jane.
Other thoughts? There's a hand. Carrie? She's muted. There we go.
And this may not be directly relevant, but it just popped into my head when you said it, which is every time we see cost reductions like that, taking control of purchasing power and using that, what ends up happening a lot of times is you do reduce it, but then you go, oh, I want this over here, and then we start adding more services, and then it doesn't actually bring the overall cost down. So I think it's we still haven't gotten to what's the model that actually is going to reduce real cost. But to your point around purchasing power, I mean, that's the crux right there, is reducing administration and seeing at what prices can we get that are lower, and that's our real levers to reducing cost. So.
And I don't see other hands up, so maybe what I can do is also provide a little context from our last discussion. I think it's obviously aligned. That point about what you do with it matters, obviously. So one thing we talked about is that, you know, we're talking about these very high-level conceptual models and their potential. But to the points made before the breakout sessions, is that the programmatic design just matters a ton. So we talked about as a kind of global strategy for navigating like the gap between these high-level models and the downstream policy that will ultimately impact how efficient you can be, and what type of pricing pressure is that. We'll use the evidence base to inform kind of that order of magnitude. Yeah, you could save this much money through your purchasing power. But we're also going to talk about and bring to you like what some of the key assumptions behind that make it possible are. So we used the example in the last conversation about provider efficiency. Well, part of how efficient they are under a single system is the level of prior authorization burden you put on them. So yes, we're going to tap into administrative efficiencies in the model, but it's also going to come with some policy recommendations and guide rails that make that possible. So maybe something similar is true with the level of savings we assume from purchasing power, in that yes, we think we can tap into that, but here are the circumstances under which that's meaningful and real.
Right, so Bevan, you are up.
Okay, so I think that there's a couple pieces here. I think that looking at the purchasing power, when you're talking about a risk pool the size of the entire state of Washington, I think could be argued that it will be significant and could expand over time, right? I would be super interested in seeing, you know, how that plays out in your data and your modeling. The other piece that I'm thinking about is that we also have legislators in Washington state who are looking to tackle the total cost, right, through drug cost transparency and through hospital systems transparency, in order to be able to kind of understand better, you know, where the true costs are coming from and how they're being handled. And I think that, you know, if we can at least have a starting point to kind of grapple with, you know, what kind of purchasing power, you know, a single payer in Washington state would have, you know, if we were to say, well, we could streamline, you know, the costs in our hospital systems, and we could potentially streamline some of our systems within our drug pricing, how would that then affect our purchasing power? So I think those are two things to kind of keep in mind too as we're looking at it. I know that this is all, we could do deep dives into any facet of the healthcare system, right, and do financial modeling, but if we're looking at it from a macro perspective, I think that those are two key pieces to keep in mind too that are being implemented at the state level.
Great, thank you. Dr. Weinberg, you are up.
I just have a really basic philosophical thing to say. First, we need to bring everybody into the tent. Then, together, we can build a better tent. And I'm using that because what we're discovering is that it keeps having its fingers go on and on and out and out into the system, that we will be dealing with mega hospitals as well as family docs in a rural county and everything in between. And we're dealing with how do you have quality control in the system, and how do you keep profiteering from happening. But first you have to have everybody in, then you can do it. Enough.
All right, Dr. Dietering.
Hi, so I think that clearly a large block purchasing power does create the opportunity to have a significant impact on rates. As far as we know that happens with Medicare. That's why everybody kind of uses Medicare as the baseline, and either you get more or less than what Medicare, and Medicare is so big that everybody has to participate. So clearly, if there was a single payer in the state, everybody would have to participate, and there would be the opportunity to take costs out of that on a unit basis. But I do know also that there's a lot of ways, if you're getting paid a little bit less for every unit, a good way to make that up is to create more units. So I do know that it really is not likely to affect what we really want to affect underlying it, which is more valued healthcare, more rational healthcare, not just more units of healthcare for more people. And I think that that's one of the reasons why just kind of thinking about doing that, you know, if we just change reimbursement to providers, that would make a significant difference, because I think it's much more complicated than that. And also, what you know, a huge portion of healthcare isn't the high-end stuff and the highly paid neurosurgeons. It's all of the home health aides. It's the folks that are being supported by this system lower down on the wage scales, and that would be impacted, right? You would start to see downward pressure on those incomes as well, which I think is a problem as far as the equity in incomes in our state. So I think those would be a couple things that we would need to be really careful about and mitigate for if this was going to be one of the aspects of because people aren't just going to be dealing with, maybe there'll be some improvement in administrative costs, but I doubt there's going to be all that much savings in there that we could harvest, quite honestly, and provide less income or less reimbursement to the various individuals and systems.
Thank you. We have others in queue, Rochelle?
We do not. And actually, there was a message that came up. Yeah, so just for the folks who are members of the public who are observing, this is time just for the work group members to collaborate and to discuss. We are not taking public comment at this time. So I know that we're going to be kind of coming back to the group here in just a couple of minutes. There was actually less than a couple of minutes. It's going to be really soon. So we might have time for maybe one more comment if someone could, someone wants to speak.
And Shane or Janine, if there's something you need to get to precisely, please jump in.
It looks like Pamela, is it Dallin, had a question?
I think she's not a work group
She's
member.
not a member of the work group.
Gotcha.
Yeah. Yep.
Okay, well, thank you very much for the feedback. I think that some of the themes that we're hearing are certainly that, yes, obviously this is transformative to go to a more streamlined system, and it will be impactful on providers, but there are a lot of considerations that we need to to take into the modeling, but also into the recommendations for the report, from things such as impact on low-income workers, but also not just a focus on the level of reimbursement, how people are paid, and incorporating a focus on value and providing the right services. Jane, thank you very much for the point to a resource to help wrap my head around economies of scale and purchasing power. That'll be very useful. Other than that, were there any other comments or things that we feel like we need to emphasize?
It looks like we are back all together again. There's folks that are coming back from their breakout rooms. So thank you very much, Betsy and Sean.
Thanks, Rochelle.
Thank you.
Hi, everyone. We're back. I'm going to spend the next few minutes. We'll do a report out on what we heard in both sessions. And I'll start by doing the cost sharing discussion. And if Jared and Nora have anything to add, and then I'll also ask the rest of the group if I missed anything. As ever, we didn't come to exact agreement on whether there should or should not be cost sharing, but there were two general camps. One camp that felt that cost sharing should be avoided because for two major reasons. One, because of a concern that it would discourage needed care, or in some cases life-saving care or preventative care that would help them avoid future conditions. And the other is the administrative burden and complication that cost sharing introduces. So a number of people felt very strongly about that. And then I think the third reason is that it was brought up a few times that they felt that there's quite a bit of evidence of the impact of cost sharing on people seeking necessary care, and not as much evidence around the potential benefits of cost sharing to reduce unnecessary care. The other camp, some folks, based on their experience and also some of the research that they've reviewed, indicated that there was some potential merit to cost sharing and its ability to discourage the use of low value or unnecessary or low volume care. They did have some specific parameters around that. First of all, that it should be transparent. One of the concerns about the current situation with our cost sharing is that often you don't even know what your bill is going to look like before you seek care. And so any cost sharing would need to be transparent. And another is that it's structured so that it does not create a situation where it could potentially bankrupt a family or individual or household, that it doesn't cause catastrophic loss for a family. I think those were the main. There were a few policy issues that folks brought up around how we could, in addition to how the model is structured, how we might seek to create policies to help allow for more access and more ability for people to seek preventative care so that that reduces their need for emergency care. And those are the kinds of things we're going to be discussing later today. Nora, Jared, or any of my work group members, did I miss anything major there?
No, I mean, the other thing I would add was the linkage between some of the policy decisions, or at least the implementation and operational decisions. They will influence this and vice versa, so that it is somewhat cyclical in terms of how they impact each other.
And the last thing I'll say about this is, while Jared, of course, we didn't come to exact agreement on whether cost sharing should or should not be included in the model, Jared indicated that he does have enough information to be able to move forward with some structure for the model around how to address cost sharing. Any
Jamie,
other?
Bevan's hand is up.
Oh, okay, Bevan. Let's see if we can get you unmuted here, Bevan. There we go.
Awesome, thank you. Just wanted to make a super quick comment that, you know, cost sharing in my mind is almost like levying a flat tax in the sense that if you have like just a certain amount per family or per person, whatever, that is not necessarily, that it can be very regressive in nature, right? So even if you're making $100 grand a year and you're a family of two in, let's say, King County, you know, you got to stretch that 100 grand quite far. But somebody, you know, in Eastern Washington, that might be a totally different situation. So I guess my point is to consider, you know, standards of living, to consider, you know, maybe not making it a flat rate, but making it some sort of progressive rate. If I prefer no cost sharing, but if it were to be put in place, that's what I would advocate for.
That's a very good point. Thank you for catching that I forgot to mention that one of the parameters around cost sharing that people mentioned would be tying it to income, recognizing that in all cases, the very lowest income folks would be shielded from cost sharing. One last point I did not bring up is the first group did not touch on this, but there was some discussion about the assumption that we've already made not to include premiums, that premiums didn't bother some people, but we're not necessarily reopening that discussion. I just wanted to bring it up. Any final fillers in on what we talked about with cost sharing before we move on to provider reimbursement? All righty, then let's shoot it over to Betsy to give us a report out on provider reimbursement discussion.
Thanks, Jamie. And Shane has graciously agreed to do this report out because we asked two very specific questions that are really in his wheelhouse. One around administrative efficiencies for the system and the other in leveraging purchasing power. So I think to be very focused, I'm going to ask him to give some feedback around our discussions.
Thanks, Betsy. And I was knee deep in conversation, so if I missed anything, please feel free to chime in. So just one of the key things that came up, in particular in the context of thinking about how you bring evidence to the table to both inform the modeling, but also as part of the recommendation strategy, that first and foremost, we should be factoring in the efficiencies from reduced administrative burden for providers into our modeling. So we will do that. But that it'll be important to include in the recommendations principles that make those efficiencies realistic, so that we can align with what we see in the evidence base. So for example, if there are things in the evidence base that suggest you need to reduce PARs in order to achieve that level of efficiency, that we make recommendations to provide similar guidelines so that it's realistic. The workgroup members identified several really important considerations that if we are to modify provider reimbursement, we take into account. First and foremost, not all providers are created equally. Both some of the reports that have been referenced and information from the members speak to a significant variation in how providers are treated in the current system, and that we'll have to think through what some of those implications are as we design our model. Examples include things such as primary care versus hospitals, or small independent providers versus large provider conglomerations. And some workgroup members also noted that for the smaller independent providers, we should keep their cost in mind when thinking about provider reimbursement. Members also noted that changing provider reimbursement impacts Washingtonians, and that when we think about modifying provider reimbursement in any significant way, that it'll be important to think about the workers that participate in those systems, in particular those that are on the lower wage end of the scale. Members also noted that it'll be really important not just to think and talk about and make recommendations for the level of reimbursement, but also what we're reimbursing for, and that we should have a focus on quality and the results that we're getting, and that we should have mechanisms within the system to focus on high value care and to remediate low value care in the system. To use evidence-based practices, and one example was provided of the Choosing Wisely campaign recommendations.
Nice summary. Shall we go to the second question?
Yes, so the second question was about economies of scale and whether or not the increased purchasing power from a single payer should be leveraged to reduce provider reimbursement. A lot of the themes that were mentioned for the last in terms of provider variation apply here. I think the key takeaway here is that yes, there's opportunity to tap into that, but we need to do a little more research in terms of where it's realistic to reduce pricing for monopoly systems, for example, and we were provided some recommendations from workgroup members where to look. And also to keep all of those other factors in mind in terms of reduction in compensation and have downstream effects that need to be mitigated.
And I think Aaron raised his hand.
Yeah, just I had to remind myself, I wanted to bring this up. You know, one of the things that COVID has shown to me anyhow is how crazy it is to rely on patient revenue to support the operation of hospitals, right? So hospitals are dependent, especially on elective surgeries. And, you know, when elective procedures went away, like half of my hospital here in Anacortes was shut down, and that's the capacity for the rest of the community that disappears because we rely on patient revenue. So I think it's worth in this, at this point in time during this pandemic to rethink the use of patient revenues as a primary source of operating income for hospitals. This may be true of physicians as well. So just wanted to bring that up.
So Jamie, I think that captures what was a very robust and not long enough discussion about provider reimbursement. But I appreciate Shane's report out because it was so very focused on these very specific questions. So thanks, Shane.
It was certainly my observation in our discussion too that we could have used more time to keep going, although I'm grateful to hear that our actuaries are feeling comfortable with the information they've gotten. I see Dr. Tritko's hand up. Dr. Tritko?
Yeah, I think that if we're going to move toward the state being a more active purchaser, yeah, of course we need to use the market power of the state. The problem that we have now is that in 4 of our 11 MSAs, the hospitals have no competitors whatsoever. In every MSA except for King County, they have more than double the market power of the health plans. A lot of people think this is a health plan problem when it really isn't. So I think that absolutely we ought to build upon the market power of the state in order to reduce cost variation and cost inflation. Whether we can drive down provider reimbursement to Medicare, I don't think that should be a goal of ours. We just need to stop the inflation and the variation to begin with, and then work on the rest of it on the long term.
Shane, do you have any feedback on that? Shane, was there any response to that, or is that?
Oh, I'm sorry, I didn't hear.
No, that's okay.
No, I appreciate the feedback, and actually it does kind of tee up a broader conceptual issue for the work group, which is your end state for this model might look different than your starting states. One of the comments from the work group was philosophical in that getting everyone covered and then pragmatically working on policy might be a better strategy. So maybe something to keep in mind, in particular as we talk about some of the qualitative drivers and recommendations, is that you can have longer term goals that don't necessarily need to be day one in the model.
So we are just about out of time. I do want to acknowledge that Dr. Weinberg's just raised her hand, and I also want to mention that one of the sections of the report in our charges in the legislative proviso is to discuss recommendations for transition. So it sounds like that's also something to what Shane and Dr. Tritko just raised are things to consider for transition. Let's take Dr. Weinberg and then we'll do our break.
Say to everybody, the rest of the world views the healthcare system as a public responsibility, and therefore government should be very much involved, if not running the system. And that it's for everybody, and that so that everybody working within the healthcare system views him or herself as a public servant. Now, if you take that and think about something, a mega hospital like CHI Franciscan that's in the process of buying out Virginia Mason, are they thinking of themselves as public servants? Enjoy your break.
That was a very good parting words, Dr. Weinberg. Let's take a break. We caught up mostly where we were behind, but I will give you the full 10 minutes because I know this has taken a lot of brain power today. So let's reconvene here at 2:44, and we're going to dive back into our breakout sessions. I'll just buy us a little time with our next breakout session. So back here at 2:44, please. Thanks so much. Okay, it looks like folks are straggling in. Thank you. Welcome back. We are going to dive into our next breakout group discussion. This is when we're going to be tackling the policy/qualitative criteria. So we originally scheduled this to be a 40-minute discussion. We're a little behind schedule by about 5 minutes, so I'm just going to shorten that by 5 minutes. So we'll still come back to the main room at, I think it was 3:20 to do our report out, and that'll make sure that we preserve our time for public comment. So New York, Liz, if you could make sure we still all go back to the main room right at 3:40, that would be great. This time we're going to go into 3 breakout rooms. We're going to have one group that's going to stay in the main room and 2 others. You'll be automatically transferred to your breakout room. When your discussion gets towards the end, as before, you'll get notifications that your time is close to the end. And then you'll get a notification to return to the main room so we can do report out. So why don't you head out and your facilitators will kind of tee up the conversation. So New York, Liz, you want to send us out? New York, Liz, I'm supposed to stay in the main room. All right.
Jamie, hi, this is Liz, Jamie. I believe I need to bring Nora back to the main room, so just give me 1 minute.
Okay, well, we'll go ahead and get started. Otherwise, I think we're good here. All right, let's go ahead and get started. So I actually went through kind of the big preamble that I was going to give you earlier in our discussion, so we can skip most of that. But again, I just want to remind you that the purpose of this conversation is to begin taking the criteria that you developed at our meeting the last time we all got to be together in person last February around access and equity and quality, and start applying it to our 3 models of universal healthcare. And we asked you to do some work at home ahead of time to get up to speed. As I mentioned earlier, for many of these criteria, or for some of these criteria, you may not be able to answer the question of which of any of these models facilitates or enables or is capable of delivering on the priorities you articulated. And that's okay too. Another thing that we're going to do that's a modification from what we discussed doing, and this was proposed by Kelly, and I think it's a good one, is if we're discussing a criterion and you feel like we need to have more data or information on it, we can make sure we make note of that, recognizing that in some cases there may not be relevant or quality research that we can draw on, but when we can, we will. And then finally, what we're really looking for today is hearing from you based on your professional and lived experiences, just as we did the last discussion, how you observe these potential models could be capable of delivering on your priorities, recognizing that, sorry, I'm getting distracted by the notifications at the top of the screen, recognizing that the real details that will also determine how efficient and effective and equitable our system is, those will be worked out in the future. So let's first of all put up on the screen the assessment criteria worksheet that you should have looked at. I'm just going to remind you what it is. And I had resent it to you this morning and suggested, if possible, that you print it out ahead of time because it will help us tackle this discussion. But this is the handout I'm talking about, the one that I'm showing you on the screen. I'm going to go ahead and take it down because I want to be able to see your wonderful faces. But I'll queue up some of these conversations. So if you don't have a printout, hopefully you can still engage in this conversation. So let's start with the question of looking at these buckets of criteria, starting with access. I want to hear from you, hearkening back to the 3 models we've been talking about, which, if any, of our models do you think is most capable of delivering on access? And by access, we mean those criteria that you mentioned when we discussed in February and that Nora walked you through at the presentation, the pre-recorded presentation. So things like seamless coverage from birth to death, providing a full range of services. Let's go ahead and start. Why don't you raise your hand and let me know your initial thoughts on which, if any, of these models are capable of delivering on access. And I see Dr. Weinberg. You get to start.
I'm nothing if not prompt with the hand raising. Obviously, to me, it's a no-brainer that the option A, which is a simple system, everybody in, nobody out, has the potential to make access comfortable and affordable and appropriate for every single person living in Washington State.
Can you say a little bit more why, Dr. Weinberg? Why do you think Model A is better than the other two with respect to enabling access?
In a word, simplicity. It's easy for people who have got other things on their mind besides the healthcare system. They don't live, breathe, eat, and sleep the healthcare system the way we do. They just, they'll know it's there, I can go when I need to, and the rules are obvious because it's the same for everybody.
Okay, so the simplicity about Model A is what, in your mind, enables the access.
Exactly.
Okay. All right, other folks, what's your observation? No feelings about this one?
Looks like Bevan's got her hand raised.
Oh, I'm sorry, Bevan, I don't see you. Oh, Bevan, can you turn your, would you be able to turn your video camera on? Sorry, I didn't see there. And thank you. Thank you so much, Rochelle. Let me unmute Bevan.
I think she's all set.
Oh, you're good. Okay, go ahead,
Yeah,
Bevan.
I'm good. So number one is I think I'm going to have to call back in because my I'm hearing a lot of really horrible sounds.
Oh no, I'm sorry.
Talking. That's okay. So if you see me disappear, don't worry, I'll be back. But I think that you know, I'm with Sherry on this one in terms of access. You know, I think that universal coverage that's state administered, I think, ensures that everybody in the state has access to healthcare. And, you know, whether that means that folks can buy supplemental on top of that or like, you know, whatever, I think that's a conversation that can be had. But this is at least starts with, you know, hey, look, everybody has access to basic healthcare, right? And I think we can sit down and talk about what's included in those plans, you know, et cetera. But it's, you know, simplicity, I think when it comes to affordability and access and equity, I think is probably the best in this scenario.
Thank you, Bevan. And hopefully when you come back in, it'll be, your sound will be better. So, Dennis.
Yes, I agree with what's been said, but the only benefit of option B is that you end up not having to recreate the world. You can end up doing as they did in Medicare. For Medicare is they have the existing system take care of the management of it with a lot of restrictions on that. And it also removes one of the big objections to a single payer system, and that is all the people that lose their jobs and just the tremendous impact that the elimination of millions of people's jobs and buildings and things such as that can cause. The legislature oftentimes looks at those, and because they look at that, it's good to give them an option of doing as they did in Medicare or doing as has been suggested so far, which is a total state-run system.
So Dennis, I want to probe that a little bit because I think that's an interesting point you made. And one of our other buckets of criteria is around feasibility. And it sounds like you're suggesting that option B could also, tell me if I have this wrong, but that option B could also facilitate or be capable of delivering on access. And when we get to talking about feasibility, you might rank that one higher on feasibility. Is that?
Yeah, if you wanted to make it feasible in a political body such as the legislature, you need to consider those things. the easiest option for a legislator is number C, which is just trying to piece by piece try to expand the coverage. The better one a better one would be B, which would of course bring it into a single payer system, but with someone else managing it. If we were lucky, it'd be C, which would, I think it's C. No, excuse me, it's A that has the state administered. The A system would be the most desirable one, but the least attractive to many of the political people that are involved in making the decision.
Okay, so it sounds like you think that A would be the best in delivering or capable of delivering on access. B, you also could see as doable and potentially more feasible to get passed. Does anyone have a different perspective here on which of the models is most capable of delivering on access, which if any? No, you're all generally in agreement?
I think Bevan's got a comment.
Oh, Bevan, are you back? Go ahead. Let's see. See if I can get her.
Oh, maybe she, oh, there we go.
Okay. Let's see. Bevan, did you have a comment?
Okay, cool. Yeah, and I just wanted to kind of reiterate what Denny was saying in terms of the political feasibility of option B. I think that, you know, I actually personally am not necessarily married to either one of these per se, and I had to kind of remind myself of option B really quick. But I do think that, you know, there's probably an argument that could be had to say that, well, look, you know, this company over here, its entire existence is basically administering health plans, right? So why not, you know, go out for a bid or something like that? I do think that it needs to be incredibly narrow. You know, if it's a single administrator, that's the best way to do it. I think that there are definitely opportunities out there that we can look at in other nations that have systems where they do, you know, bidding systems, or there are public-private partnerships in terms of administration that could be looked at and you know, as kind of a guide. But the minute we start bringing in all these multiplayers, we get back to square one, which is where we are. So coming as far from there as we can feasibly is the best bet as far as I'm concerned.
I think it's interesting that we've kind of jumped to the feasibility bucket. That actually sounds like something that's going to be of definite interest to this group to discuss more, but I think I'm hearing some consistency that folks would prefer option A for access, but option B is possible and potentially more feasible. Ronnie, you're up. Trying to unmute you here. Giving me a hard time. New York, Liz, can you help me out with this? I'm not able to unmute Ronnie. Okay, Ronnie, I apologize. I'm going to have New York Liz work on unmuting you, and I'm going to come right back to you as soon as we can get. Oh,
so
no.
I was able to unmute myself.
Okay. Woo! Yeah, it's great. Okay, go ahead.
So I think option C of filling in the gaps, as Dennis said, is the easiest to accomplish politically because it's going on. I mean, we're trying to do that as best we can, but it creates a cherry picking by the insurance companies. It creates a second level of healthcare, and it really does decrease access by companies, insurance companies stepping in and saying, we're only going to allow access to certain areas or certain providers. And that can be a real killer in a rural area where there are limited providers, where there are long distances, and that's the opposite of improving access. So it's certainly, we want to, to fill in gaps as best we can, but it's not the answer. And if a Medicare type program of Model A or Option A is our ultimate goal, we really need to present that as a key issue, even if we know that there will be steps along the way. That option B just seems like something that we don't want to propose. We want to move towards a comprehensive program that we know has been proven to work in the United States with Medicare, and that, you know, stopping at option B or recommending that as the ultimate option is a mistake. We need to move towards that single payer or a government payer coverage.
Okay, so I'm hearing you say that of the three options, option C is the least capable of delivering on access, even if it might be the most feasible. And you also would caution against stopping at option B when access would be best delivered with option A. Jane, you have your hand up.
So as I'm looking at the access includes issues such as on the sheet, I think it's the underlying design of the program so that option B could probably do these things depending upon how you design the program. And when I think about the references to Medicare, CMS delegates portions of administration of Medicare Part B to carriers around the country. I don't know that they're called carriers anymore. Chris might be able to correct me. But the concept of, you know, Medicare is a single payer system, but the system is not exclusively administered by CMS. So I just thought I'd point that out. And
So
also, it's a matter, I think, of system design as between A and B.
Okay, so it sounds like your opinion is that either A or B could be capable, but it really is the devil's in the details, and it's about how the system is designed and the policy implemented that would ensure access.
Yep.
Okay. I see Ronnie's hand, and then I'd love to move on to governance if we can, unless someone has a differing opinion. See, Ronnie, I just asked you to unmute. There we go. Cool.
And I think Jane's issue is really an important one for us to consider, which is Medicare has, or CMS has, regional offices that make those decisions. Washington State is in such a great position with our Infrastructure and Healthcare Authority and our Office of the Insurance Commissioner. We are so far ahead of many areas of the country that allowing us to develop a system would be ideal. So I think that issue you bring up, Jane, is an important one, but I think it's the one that really gives us an improved chance at moving in that direction.
So Washington's actually well positioned to maybe implement some of these policies that Jane is raising. All right, we're gonna move on to governance and a reminder of some of the criteria around governance. This is about ensuring transparency and accountability and how the model is governed, participation by community-based systems and organizations in its governance, respects of the primacy of the patient-provider relationship, administrative accountability, tribal sovereignty and voice are preserved, and the patient voice is preserved. So let's, the three models, what are your opinions on which, if any of these, are capable of delivering on this criterion? My most reliable hand raiser, Dr. Weinberg.
Well, I actually did my homework, so I have my answers here. I think I've answered model A on all of the issues under governance. If you have a single administrator, especially if it's the state of Washington through its healthcare authority, you can certainly make that transparent and accountable. You just write it into the law, and all the meetings will be open, etc.
So that simplicity thing you raised before also facilitates governance.
Right, right. I also said in terms of participation by community-based systems, organizations, and so forth, we never really have thought about that before. That's sort of new. but it depends on the design. If that's, we're getting into more inclusive input, and that should be included in design. And again, when you have one system, it's easier to include all of that. And again, respecting the primacy of the patient-provider relationship. That's, again, a feature of the design. And if you have one system, you can do it. Now, as soon as you do option B and you have insurance companies in there, not only have you increased costs by adding an extra layer of administration, but you've also added all the network lists. No, not network. You can't go see that. You've got to get this insurance company's approval in order to do whatever it is you want to do.
Understood.
So I could go on, but I won't. Let's see.
Thank you. I'm gonna call on
That's
Ronnie.
right. Go ahead.
Appreciate it. I'm going to call on Ronnie, and then I'm also hoping some of our folks who haven't spoken up yet can share. Vicki, I was going to pick on you because I thought governance might be of particular interest to you. So hope that's okay. But Ronnie, you go first, and then we'll go to Vicki.
Even adding in insurance companies, the big issue we find as providers is that it's the insurance company making a lot of those decisions by their own individual guidelines. The state can certainly establish the hierarchy or the primary essential services. And as I said a few minutes ago, the Office of the Insurance Commissioner can really enforce a lot of that. But once we put the insurance companies in there are all of these hidden issues that come up, or programs, benefit managers. I know in pharmacy, when I call someone with a specific insurance, I could be getting a completely different benefit manager depending on who who the plan is through. And it just brings up other controls that are not transparent and that can really interfere with providing care.
So Ronnie, it sounds like option B feels less capable of delivering on the governance that we've articulated here than option A. Is that accurate?
Yes.
Okay.
Thanks.
Okay, I'm going to call on Vicki now, and then Bevan's got her hand. Oh, I'll call on Vicki, then Bevan, and then Dean. So, Vicki.
Well, and I think option A definitely for governance in any relationship, and especially like the tribal government to government relationship. The more people that get in the middle of that, the more the relationship is degraded. And as Ronnie said, that the more of the different conditions, and we experience that in the Medicaid system with the managed care organizations a lot, where you have an agreement with the healthcare authority, but once that contract gets in between you and your agreement with the healthcare authority, then you start to have issues and payment problems. So I think option A, as far as governance, makes the best sense to me. You're muted. I think you're muted.
Thank you, Vicki. Let's see. Bevan was next, and then I saw Dean raise his hand. Bevan, let's get you unmuted here. There we go.
Awesome. I also, of course, choose option A for governance. I will say that I think with option B, there is certainly the possibility to, structure the, to put the policies in place in terms of what's covered, and then, just have a third party administer the claims so they don't get in the way of choosing what is being covered and what's not being covered. So, I obviously would shoot for A, but I do think that there's a way to kind of build option B in a way that we could safeguard, that the issues around insurance companies deciding what's covered, what's not covered, network, not network, et cetera, et cetera. So, you could write it into the law that it's specifically only to administer the claims, and then what is provided within is, the legislature decides on that, and that part is the, kind of public process, right? So I think that there's an argument to be made that option B could be a possibility in that sense, but I think governance is going to be easiest in option A for sure.
Okay, governance is easiest in option A, but I'm hearing that if with some design, we could accomplish that potentially with option B. Dean, you raised your real hand.
Yeah, so I can't find the hand raising button.
Sorry, I got you.
Else at work. So, yeah, again, not to be a dead horse, but I think A. With B, while I agree with Bevan that, you know, it could be done reasonably, that anytime option B has two cooks in the kitchen, right? You got the state and you got the private administrator. Which can cause problems in contracts and that kind of a thing. Also, when you're talking about transparency, accountability, and a lot of the things that government does, those things cost a lot of money, and they would eat into the profit margin of a private company. And
Sure.
you know, you could make them do it, I'm sure, but you know, if you don't, then you know, those are going to be harder decisions for them to make on whether to provide kind of the transparency, accountability, customer service kinds of things that would eat into the profit margin. So
Okay, sounds like you're echoing then on option A for governance.
yeah,
Best choice. Also just because of some of the motivations of our insurers in option B. Anyone who we haven't heard from? Sybil, Representative Schmick, Chris, Mary Beth, Carrie, any feedback on this one before we move on? You're good? You agree with what you've heard so far? Oh, I see Mary Beth.
I just to weigh in, I do agree that option A is better for governance. I agree with Vicki, and that's the same for community-based organizations that are involved with public health, even the accountable communities of health. Sometimes the lack of transparency with the managed care organizations beyond the contract is very hard to. It's very hard to have conversations that lead to actual community decision making sometimes because of the nature of what's kept proprietary and what's transparent. So I think for that reason, I'd support A as better for governance.
So it sounds like the fragmented system leads to compromising some of our criteria, like the community-based organization participation. Representative Schmick, did I see you raise your real hand there?
I'm good. I'm just.
Oh, you're good. Okay.
Sorry.
I like your background, by the way. All right, let's move on then to quality and equity. And just a brief reminder of what fell here. This is incentivizes or enhances the delivery of quality healthcare and includes efforts to improve healthcare safety and minimize medical errors, encourages transparency of health quality, including reporting of adverse events, and encourages consistency in healthcare delivery in rural areas and across different cultural, ethnic, language, and other types of communities. So which, if any, of our models is most capable of delivering on quality and equity from your perspective?
And just to jump in,
oh, yep.
we recognize that quality and equity are different things. But as we were putting together the list, we thought about kind of how do you measure equitable outcomes and quality, thinking about it in terms of different races and ethnicities and rural versus urban and all these things. So we ended up putting them together because there's so many procedural crossovers.
Thank you, Nora, for reminding us of that important part from your presentation. Vicki, and then Dr. Weinberg.
I beat Dr. Weinberg. I feel like a game show. Well, again, for the same reason I picked A for the governance, I pick it here because, you know, people have different ideas about what equity and you know, how that plays into evidence-based practice. And then from communities of color and our cultural practices, just having that conversation with one entity rather than having to get it translated to other entities would, you know, have better outcomes, in my opinion.
Again, the fragmentation of option B
is, yeah,
compromising our criteria.
And we experienced that already in the Indian healthcare delivery system.
You have real world experience with that. Thank you, Vicki. Dr. Weinberg.
This really matters how you design it. As one who was involved in the writing of the Washington Health Security Trust 22 years ago, we dealt with this by assigning 3 standing committees to deal with quality issues, to deal with what do you do with new treatments or medications or whatever, and public input, having a committee that's specifically designed to hear public concerns and deal with them. These are all the kinds of things that need to be done by a board that is running the health. If you have a single board running the healthcare system, they can pull all of these thoughts together and design the kind of supervision that is needed to change from a profit-oriented healthcare system to a public service-oriented healthcare system, which is what we're talking about here.
So Dr. Weinberg, it sounds like this might be one of the criteria where it really is how we design the system.
Right, and it's easier if you have one group to deal with than trying to dictate to 17 insurers. We'd never get 17 insurers in this state, but however many we would get, having to keep them all in line and behaving themselves is more difficult.
Sure, sure. Okay, we are at 4 minutes. I see Ronnie and then Bevan. We're having a mute problem again over here. So, oh, there we go. Go ahead, Ronnie.
So as far as quality goes, I think that insurance companies do have some great contributions to make. There are good players and there are players that are there to raise, emphasize cost savings as a quality issue. But I think that any of these programs can really improve the quality of care as long as we as a create or emphasize the government's role, our government's role in making that happen. So I think certainly that having a uniform plan for everyone would be the ideal, but I think this is an area where we can count on innovation to make contributions. We do need to enforce and pick out the players who are there for profit.
So Ronnie, it sounds like this is a situation where option B maybe could have some advantages because the opportunity for innovation, as long as we're very careful in the design. Bevan?
I'm in terms of the equity piece, I'm just going to, bring in our cultural sensitivity training to these models and also, the social determinants of health, right? And I think that there's definitely room for public-private partnership in the research in this area, right? And I think that quality can really differ depending on what community you come from, right? And how we define quality differs. And I think that when we move to more value-based care rather than, fee-for-service care, that is also going to be a component of this section that I think is going to be able to kind of highlight where the strengths are in each of these models. So I think this one is a little bit harder to kind of say it's either this one, or this one. I think that this is one of the ones where we need more research. and input, right? From especially from people who come from diverse communities, and I want to make sure that their voices are at the table too.
I've heard a few of you say that this one is probably more dependent on design, but I'm going to make a note too that in our last column where we say we need more research and information, particularly around equity in communities of color, that's somewhere we should look. Sybil.
Hey, so yeah, I would agree. And I think that we'll have to pay really close attention to this issue of equity no matter what design we choose. I think we're doing a terrible job in this area. So yeah, that's all I would add, that I think this would just take a lot of work to get right. And it's not clear to me which model would make that easier. I think that, yeah, I think that there are problems when we have big purchasers, and there are problems when you have many individual purchasers. So yeah.
So, and we're not going to get a chance to talk in depth about my second question, which is around more like what we should be doing a deeper dive into of these criteria. But I'm taking from this that equity is one of them, and that I'm hearing that criterion may be agnostic to which model, and it's again about design, but we need to have more information on it. We've got, I think we're going to be revisited by our folks, but in the minute while we're waiting, just want to go back to the feasibility and administration criteria. I heard, and this did not surprise me, we kind of jumped to feasibility. I heard from a few of you that we would go in reverse order on feasibility, C, B, A, but because of your concerns about how that might compromise our criteria in other categories, you wanted to talk about feasibility and administration together. Really quick, does anyone have anything to add to that before our friends rejoin us?
Oh, I'll say something.
Yes, Dr. Weinberg.
I think if we were to choose option C, we might as well not have saved the state of Washington $500,000 in running this committee, in running this work group.
So your opinion is that C would be a waste?
Yes.
Okay.
It won't get us anywhere. It won't control any costs, and it'll improve access, maybe 2,000 people at a time, at each one at the expense of additional administrative hassle. So
okay.
Anyway, I could go on, but I won't.
Mary Beth, I'm so sorry. I think, but if you have anything to add when I'm doing the report out, please do jump in then. Hi, everyone. Welcome back. I think, do we have all of our groups back? I'm trying to count all your faces here. Looks like looks like we're getting everybody back here. Great. All right. I will kick off the report out, and I think just for the benefit of efficiency, I'm going to run through what we heard from folks about all of our categories, and then what I'll do is I'll go to Liz and then Betsy and ask them to build on what I've shared. So if there's anything different that your group provided, or if you echo it, that would be really helpful. And work group members and subject matter experts, please jump in if I forget anything. We started with access as we were instructed to, and generally the group agreed that model A would be most capable of delivering on access, but there was also some agreement that model B could also deliver on access depending on how it was designed, and feelings that model C would be the least capable of delivering on our access criteria. Interestingly, this group quickly jumped to balancing access with feasibility. They wanted to go and talk about our feasibility criteria as well. So I thought that was actually very interesting that our discussion was nested around, yes, option C may be the one that would be easiest to make happen, and then option B, and then option A, but it goes in the reverse order in terms of its capability of delivering on access. With respect to governance, there was kind of mixed agreement. Generally, a lot of people said that A was capable of delivering best on governance, and this was particularly around tribal sovereignty and voice. Our criteria around tribal sovereignty and voice because, and Vicki mentioned that because of the tribal government to government relationship, it's just much easier when you don't have a fragmented system. But there was also some agreement that with some of our criteria, particularly around participation by community-based systems and organizations, that it is also really dependent on how we design things. So it may be that it's not just which model we choose, but also the policies that we develop and implement. With respect to quality and equity, there again was thinking that Model A would be the most capable of delivering on quality and equity. But this was actually an area, particularly when we were talking about our equity criteria, where there was agreement that, there were comments that this may be delivering on our equity may be agnostic to which model we choose. And it's really very much about the details and the design. And this was also a place where our participants mentioned wanting more research and information to deliberate more fully on this. So this was an area we pinned as something we'd like to do a deeper dive in future meetings. And finally, getting to feasibility and administration, I already mentioned, we kind of shot straight to that. But generally, we agreed that C would be potentially the most feasible, but from the perspective of delivering on all the other criteria we've articulated, possibly the least desirable. So quick summary, generally people felt that A could deliver on our criteria most capably, but that B was possible for a lot of criteria depending on our design, and C was kind of a no-go except for feasibility. So I'm going to pass it on to Liz now and ask you, Liz, to build on what we shared from our group, different or echoing.
I'm going to ask Shane to pipe in because he was taking notes for us.
And maybe not surprisingly, but the conversation was very similar and had many of the same points. Just a couple of the differences. We talked about the group needing to get a little more information about what it actually means to provide culturally attuned care, and also a little more information about least restrictive settings. And I think a really important and interesting comment that came up in the access conversation was that option B could potentially be more preferable because there's already network development that happens with the plans. And that actually ties back into the group was already thinking about that whole feasibility concept. So I think that's just resonating across the board. But generally speaking, A and B is superior to Model C. In terms of governance, the group really summarized it with a single concise point that what's going to be key is that we have authentic consumer and delivery system representation in governance. In terms of ranking the models, A, B, C. So for a lot of the similar reasons. For quality and equity, the question was raised on whether or not we should actually consider these separately, that equity may be best served as its own category, and potentially pulling in that aspect of examining culturally attuned care as well. The group noted that all of the models can achieve these things, but that A and B likely have greater leverage to do so. Administration and feasibility, again, just hammering home on that feasibility. We thought it might be better to maybe break them apart and examine them separately because they are quite different. The capabilities of A and B to deliver on the goals of the models are higher, but inversely related to feasibility. So it's actually harder to execute and get there. So pretty much everything resonated, and those were the key points for our groups.
Thank you, Shane, very thorough. And then we'll go to Betsy, and then I'll check in with the larger group to see if you have anything to add to what you heard. So Betsy, you're up.
So I'm just going to speak to what was unique to our group. A lot of the same themes resonated. I think generally our group went with kind of an ABC order as well. The interesting thing for us was that there was a lot of discussion about it depends. So a lot about how you implement, a lot about what policy considerations are taken, a lot about what systems are out there, to help us understand how we might implement. And it was mostly about a single payer system. And the idea that a single payer system could be a precursor to getting to many of the criteria and really understanding better. And I think this takes us all the way back to the beginning of the day, where we had the conversation about what the evidence base is, where the data is. You know, could we look at some systems that are doing, and again, we're talking mostly about single payer, what are they doing well? How are they addressing, to the extent that we know with evidence, the criteria, and then, you know, building from there. So I think our group kind of ended up looping back to this idea that as we're teeing up the next conversations, we could be doing some lit review and deeper dive into systems and, you know, various systems. And one was PEBB that we talked about here in Washington State, that could help inform what we want to design. And then from there flow the policy and implementation considerations. So it was I thought it was a great conversation.
And to clarify, I believe most of you know this, but I believe the acronym you just used, Betsy, is referring to the Public Employees Benefit System. Is that accurate?
It's actually Public Employees Benefits Board, PEBB.
Thank you. Thank you. I was wondering what that last B was for. Thank you.
Yeah.
All right. So work group members, did we miss anything important that you brought up? Did we catch it all? Okay, see if there's any hands. I don't see any. It sounds like.
It looks like we got Vicki Lowe. Yep, Vicki Lowe.
I didn't say this earlier because I've been kind of formulating it in my brain. While you were,
yeah, Vicki.
Can you hear me?
Yeah.
Okay.
We can hear you.
Okay. But, you know, when we talk about quality and equity, I just really worry about the voices of marginalized people who haven't had access to either quality care or equity in care. And we talk a lot about money here. And to me, I'm worried about that being too important. But however, in the Indian healthcare delivery system, you know, we provide very good care for Indian people throughout the United States. It's grossly underfunded. 32 cents for every dollar we need to, provide care is what is funded. So it is important that we have a system that has enough funding to provide the appropriate care. But the appropriate care is the piece. And I keep hearing the words evidence-based practice. So who is that evidence based on? And I'd like to hear more practice-based evidence as well, because that would be culturally appropriate care. And I just want to make sure that that's a part of the conversation too. Thank you.
Vicki, I'm hearing you're raising in particular a criterion around culturally attuned care, and that, well, I've heard a couple of things, but I heard you mention around culturally attuned care. We need a caution, first of all, that cost should not be the only driver. A caution that evidence is tricky, particularly when we're talking about culturally attuned care, and that you would like to see us looking at practices and what's happening in the field, not necessarily peer-reviewed studies. Or I'm building on what you said, but I just want to make sure I understood. And again, I said, as I mentioned earlier, in the group that I facilitated, of which Vicki was a part, it became clear that equity was definitely, and I think I'll add culturally tuned care to that, definitely a place where we could really serve to do a deeper dive there. But I'm hearing a caution that we be really thoughtful about the evidence we seek out for that. I see Sybil raising her hand. Let me find Sybil. Where are you?
Yeah, I was unmuted. Thank you.
Okay, great. Thank you.
No problem. It's good to have a team. So I just wanted to add, when we talk about equity, that we oftentimes in our conversation, we might think that people of the lowest incomes are going to be the only ones that face racial disparity, but particularly in the Black community, you see that across the board, across the spectrum for people of all classes. So I want us to understand that, yes, you are going to be more impacted as a lower income person, but race and class are not the same. They're two separate and distinct things, and that they need to be addressed in coordination, but they're two different things. The second thing I wanted to add was that when we look at racial disparities, a lot of what's happening is that people are just not listened to. People's pain is dismissed, particularly again for the Black community. People just think that we are superhuman. A lot of they've had research showing that medical students think that Black people have thicker skin, for example, which is not true. And that impacts the way that people think about our tolerance for pain. And so if someone requests pain medication or if someone expresses a medical concern, they're less likely to be heard. So I think that any work we're doing in equity has to understand these things, and perhaps as part of value-based design or something, we make sure that we're incorporating those experiences and that we are incentivizing proper care for people that actually listens to their needs.
Thank you, Sybil. That actually brings to mind, I'm thinking, it's funny, I'm picturing the final report in my head and the outline of the final report, and particularly the section about policy considerations and work to be done. And I might recommend that we talk about some of the examples, like the examples that Sybil just brought up, as areas where there are a lot of complexities that are going to require some deep and thoughtful work beyond when this committee sunsets, and that we might have some recommendations about that for the final report. But Sybil, I think some of those examples you just brought up are really useful to illustrate how important that is. We're at 3:35, so it's time for me to go through action items and next steps. Before I do, any final comments? Okay. So I'm just going to remind you of what we have next. We are convening again in September. I think it's September 16th. In the meantime, you should expect to be hearing from us about the plan for both the fall meetings. Consider the September 16th meeting on as scheduled, but we might be looking at how we do the October and November meetings. We'll have to do some discussion on that, but we'll get back to you as soon as possible because I know your calendars fill up. We will also be providing you with a timeline for developing the report so that you know when to expect getting a draft for review, and you'll be able to see how our deliberations lead up to completing a draft report. As ever, we're going to be producing recordings of all of the deliberations today, not just in the main room, but also in the breakout rooms, and posting them online. I will notify the work group when those are posted, and I believe Rochelle and the HCA team will be notifying everyone on our listserv. Also, and this is germane to the public comment we're just going to do shortly, I know that we're getting to the point where the 20-minute public comment at the end of the meeting is not enough for the amount of interest in public comment, so we'll be discussing how best to address public comment in the future meetings to make sure that the work group has the benefit of hearing from our public. That said, I just want to remind our folks making public comment today, if you don't get, first of all, I want to express strong appreciation to the 41 people who signed up to make comment. We so appreciate your engagement in this process. I want to remind you also that if you do not get called on today, please do submit your written comments via the HCA website, and we will make sure that our work group members see them and get an opportunity to review them. Quick reminder of how we're going to do this process. I have a timer I'm going to put on the screen. I'm going to call your name, and what I'm going to do is call 3 names so that folks know when they can be expected to be called up. We are going to be strictly enforcing the 2-minute timeline so we can get as many people in as possible. So please do keep your comments to those 2 minutes, watch the timer. I will be, and I hate to do this, but I'm going to have to, I will be muting you if you go over the 2 minutes, and we'll be moving on to the next person. So please don't put me in the position of doing that. Keep your comments to 2 minutes. Also, if you have a written version of your comments, it would be great if you could send that to the HCA email box, which again, you can find on the website, and we'll make sure we share that with our work group members. As you can imagine, I imagine their brains are a little tired after all this deliberation, so it'd be great to have written versions of your comments. So with that, I am going to share the timer on my screen. All right, and so I'm going to call the first 3 names, and you're going to be called up in this order. So we're going to start with Cindy Laws. Oh, and again, please forgive me if I mispronounce your name. I will do my best. Cindy Laws, followed by Marcia Stedman, followed by Bruce Cutter. You will have 2 minutes. If you could state your name to start, that would be great. And then you can speak. And can I ask one of my team members to unmute Cindy Laws first?
Yes, I'm working on it right now. Give me just one.
Okay. Hi, everyone. Thank you for allowing me to speak. My name is Cindy Laws. I helped lobby this legislation in the first place, and we have the size of the work group because of the work of Healthcare for All Washington, and we were able to get that work group expanded substantially so it reflects more voices. I want to emphasize a couple of issues. 71% of Americans support publicly funded universal health care, which is Model A or Model 1, whichever we're calling it today. I think the important thing to emphasize is when folks are talking about cost sharing, that cost sharing, we're in a really unique situation right now, and we have to seize this opportunity. Cost sharing leads to such things as health inequities. When the burden of seeking care becomes so high that people don't seek care or don't seek adequate care, then they have worse health outcomes. And we see that result right now with the pandemic. We see an unholy amount of people of color who are much more likely to be dying and become exposed to coronavirus. So making sure that we're taking heed of what's happening right now in real time is really important. So I don't want to have anything that has anything to do with cost sharing. I want to see any evidence when people say that cost sharing is a good thing, because denying care is not a good thing. The cost of healthcare in the United States is high because of the prices of healthcare, not because of usage. And we need to focus on making sure that our people are healthy. And so that is the number one thing. Option one is the only way to go. It's what Americans are demanding. It's what our people need right now.
Thank you. Next up, the next three names. Next up is Marcia Stedman, followed by Bruce Cutter, followed by Anu R. So let me know when you have Marcia ready.
New York, Liz, I'm unable to unmute. Can you do that for me for Marcia Stedman, S-T-E-D-M-A-N?
I just unmuted myself.
Oh, great.
You can hear me. Okay.
Go ahead, please.
I wanted to ask if I could cede my time to a certain person who is also signed up, so to make sure she gets heard. And her name is Erin Fenner.
I'll make an exception this time, Marcia. I'll have to think about our policies.
Okay. I just want to say first that I agree with the general tenor of this group, and I think you're on the right path in recommending option A. Thank you.
Okay. Thank you, Marcia. So that'll be okay this time. We'll do Erin Fenner, but then we'll have to revisit our comment policy. So can you unmute Erin Fenner, please? We'll be going in place of Marcia Stedman.
Thank you. Thanks. I'm Erin Fenner with Washington Can, which represents more than 44,000 members throughout the state. I'm going to share a story from one of our members who doesn't want to use his name because he is an undocumented immigrant. If you would like to speak to this member, please reach out to me directly. I'm at Erin@WashingtonCan.org, and I can facilitate that meeting. Our member, who is a renter in Seattle, has a chronic life-threatening condition that he has gotten multiple costly surgeries to treat. He needs another surgery this year that is high risk and high cost, but is the only treatment that can give him a chance at survival. Unfortunately, he lost his job in March due to the pandemic, and he has had no financial assistance from the federal government because of his documentation status. Now he is nearly $20,000 in debt in rent, just from missing rent since March this year, and is afraid that he will be evicted from his home after Seattle's eviction moratorium is lifted at the end of the year, because he cannot count on the moratorium being extended indefinitely. Unfortunately, that doesn't give him the time he needs to get this major surgery and then also recover from the surgery. He told me that he needs at least 6 months to recover, and he also, needs time to set it up with his doctor, which means that there's a lot of unpredictability for him. Our member just wants to get back to normal, contribute to his community, like so many people who are in a situation, so many undocumented families across our state. But he's stuck struggling to afford even the most basic necessities, including food, which of course has exacerbated his health condition. While it's clear that employment or cost should never prohibit somebody from getting the care they need, we need to make sure documentation status also should never be a barrier if we were going to put health and human dignity above profit. It's critical that immigrants, regardless of their documentation status, are included in our plans, policy, and vision for how we recover and get through this pandemic and thrive at the other end of it. Thank you so much, folks.
Thank you. Okay, next up is Bruce Cutter, followed by Anu R, followed by Sherry Van Hoover. So Rochelle, can you let me know when you have Bruce Cutter unmuted?
Bruce is there.
I'm here. Can you hear me?
Yes.
Yeah, thank you very much. Appreciate the opportunity. Name is Bruce Cutter. I'm a physician in Eastern Washington and Spokane. Appreciate all the work you have all done. I've got 3 sort of general questions and a few comments. One question is to ask everybody, why are we here? Another question is, can we reimagine and communicate a better system of care, as you all are trying to do? And as part of that, can we adopt a different basis of compensation and competition, not based solely on cost shifting and monopolization, primarily on those factors? So appeal for change. A couple of short comments under cost sharing. What are we trying to accomplish with the different proposals? And what is the evidence that we can in fact accomplish what we're trying to do? And also to keep in mind, how will this sell to the population of the state? Under provider compensation, once again, what are we trying to accomplish with the different proposals? I would ask people to remember that the issue is not just revenue, but also income. So there's a whole cost side of things. Also, not all providers are created equal. There's lots of nuances, different kinds of businesses. We've only just hit the superficial aspects of that. I think the different 1 versus 2, I think it depends on the details. And I guess I'd ask the committee to be very explicit. If you're going to choose 2, I think that has potential, but what value added will bringing these intermediaries to the table show? And also that can be a selling point. That's all I have for today. I appreciate everybody's work. Have a good day.
Thank you. Next up is Anu R, followed by Sherry Van Hoover, followed by Rian Ametu.
Hey, Jamie, can you spell the last name of the next speaker for me, please?
It's actually just the letter R.
Oh, okay. Let me see here. Okay, what was the first name? I'm sorry. I'm trying to get this.
A-N-U.
I'm sorry, it cut out. Can you tell me one more time?
A-N-U, and the last name is R. And Anu, if you're here, if you could raise your hand, that would help us find you as well.
I don't think that they're on.
Okay.
Yeah, I'm not seeing them. Okay, so who's next?
Anu, if you are on, let's do Sherry Van Hoover, followed by Rian Ametu, A-M-E-T-U, followed by Jim Howe. And Sherry spelled with a C-H-E-R-I.
Hi, my name is Sherry Van Hoover, and I'd like to thank this group for the thoughtful and important work that I've been observing today. As president of Midwives for Universal Healthcare, a caucus of the American College of Nurse Midwives, I'd like to underscore the reality of this nation's crisis of maternal mortality. This crisis is a social justice and reproductive justice tragedy, disproportionately impacting Black, Indigenous, and people of color communities. Universal access to culturally appropriate healthcare is essential to solving this problem. All of the world's most successful universal healthcare systems fully integrate midwifery care as a key element. The midwifery model of care has been amply demonstrated to improve health outcomes, the appropriate use of technology, and patient satisfaction while decreasing cost. And I'm a little concerned about the composition of this work group, since according to the published roster, there's no midwifery representation here. So I just hope that all of you will focus tightly on reproductive health and the needs of childbearing families in all of your discussions. And I ask that you consider adding a midwifery voice to this work group or future groups. Thank you.
Thank you. And I'll just remind members of the public who are making comment, if you are able, please do turn on your video camera when you're making comment. It's nice for us to be able to see your faces as you're making comment. Understand if that's not possible for you. Next up is Rian Ametu, followed by Jim Howe, followed by Chris Covert-Bowles.
Okay, Jamie, hang on. Can you spell that last name for me, please? I don't. My spreadsheet that I had earlier is not functioning, so I'm sorry for the delay.
Okay, it's A-M-E-T-U.
I am not seeing Ametu.
Okay. All right, please message us, Rian, if we've missed you, and I'll move on to Jim Howe, followed by Chris Covert-Bowles, followed by Kathleen Myers.
Okay, and Howe is H-O-W-E? E? Okay. I'm not seeing Howe in here.
So Jim Howe, please message us if we've missed you. Chris Covert-Bowles, followed by Kathleen Myers, followed by Al Bergstein.
Okay. I'm not seeing Covert, C-O-V-E-R-T?
C-O-V-E-R-T-B-O-W-L-D-S.
No, I'm not seeing this person either.
We'll be looking out for messages from all of you. So Kathleen Myers, followed by Al Bergstein, followed by Michael Benefiel.
All right.
Just ask Kathleen to unmute.
You ready?
I've got Kathleen Myers. I've got you, and I've just asked you to unmute. Are you able to unmute?
Okay,
No?
We'll go on to Al Bergstein, and then we can go back to Kathleen. Al Bergstein, followed by Michael Benefiel, and then we'll go back to Kathleen if she can unmute. So Al?
Okay, I'm not really quite sure what's going on with participants. There might be some folks that are kind of hopping off, but I'm not finding folks.
That's okay. How about, I just saw Michael Benefiel. So
there's quite a few folks, quite a few fewer folks on than who registered. So that's,
we'll just keep tagging along here. So let's go with Michael.
All right, Michael, you're on.
Okay, can you hear me?
Yes.
Okay, I'm Michael Benefiel. I'm from Kitsap County, and if we really want to provide affordable and comprehensive health care, we must have a single payer system where the government pays the providers. Option A should be the only option we provide to the legislature. If it needs, it would need a transition, of course. I would not recommend using option B because that would, I don't believe the legislature is real enthused about a single payer system, and I wouldn't give them the option of accepting just a option B and never going to the single payer system. And option C, of course, to me looks like exactly what we have. Also about option B is what you got to realize is that the insurance carriers are not apt to go along with the control that the state will want to put on them, and if they don't, we'll have wasted all that time, because like with Cascade Care, they're having a hard time finding carriers that are willing to live up to the control that the state wants to put on them. That would happen with option B, I believe. Okay, thank you very much.
Thank you. So we had next on our list Jen Bartel, but it looks like that person's no longer on the call. So we're going to go with Alan Unel, followed by Bokuhi excuse me.
Hovagimian, and you know what? We can do them together because we're married.
Oh, wonderful. You're together. Great. Thank you.
So my wife, Fokui, I don't know if you can see her. I'm Alan Unell. This is my wife, Fokui Hovagimian. We are retired, and we have an issue with the current healthcare system. First, let me say we support option A, single payer, not just in Washington State, but actually nationwide. And here's the story. Our daughter is in school, and she's going to be 26 shortly. We cover her on our healthcare policy now. It is expensive. For her alone, we pay about $1,100 a month. Our daughter has lupus. It is not curable. Hers is not curable. And if not continuously treated, the consequences for her will be deadly. We will find a way to pay for her insurance when she turns 26, one way or the other, in a couple of months. But the fear is that down the road, she may become ineligible for health care because of serious pre-existing conditions, lupus. I pray that she never winds up on Medicaid, since the formulary is controlled by state legislators. And in some states, Medicare has actually, not Medicare, her medicine has been actually removed from the Medicaid list. Kentucky is one of those examples that actually removed lupus medication. And the result was actually deadly for people there. We need a single payer system, government-funded insurance to private providers in order to preclude this. It should cover everybody in the United States, cradle to grave.
Thank you.
Thank you so much.
Thank you very much. Next up, we had a couple of names that I understand are no longer here. So we'll go with Rich Legg, followed by Kirk. I'll reset the time, don't worry. Followed by Kirk Anderson, followed by Jason Larson. Let me reset the time here.
All right, Rich, I've unmuted you.
Thank you. I would just like to express my support for the single payer option, the first one, because it's the one that actually solves our problems. You know, they're getting much worse currently with the pandemic, and it solves them in a simple and straightforward way. Thanks a lot. That's all I have to say.
My apologies, folks. I'm multitasking here. Next up is Kirk Anderson, followed by Jason Larson, followed by Joseph St. Aubin.
Okay, so the first two that you just announced are not here anymore, but let me see if I can find St. Aubin. What was the gentleman's first name?
Joseph.
Oh, here we go. All right, asking to unmute. Joseph, can you hear us? Can we hear you?
Joseph, are you able to unmute?
Hello.
Oh, ready?
Just a second. I have hope. There we go. Yes.
My apologies.
My name is Joseph St. Aubin. I'm a low-income quadriplegic that relies on Medicaid to pay for caregiver services. When my caregiver is away on vacation, I check into a nursing home until she comes back from vacation. I try to pick the best quality nursing home care that I can find. However, nursing homes like to cherry pick the potential patients, usually based on what type of medical plan they have, which puts me in a major disadvantage. That is why I believe Washington State should choose a single payer option. By eliminating the competition, it will allow someone like me to be able to choose the highest quality nursing home care that is available. Please recommend that Washington State should choose a single payer option for universal health care for all Washingtonians. Thank you very much, and I don't believe in any cost sharing. Thank you.
Thank you. Next up, we have Kevin Wren, and we'll have time, I think, for one more comment after that. So that would be followed by Jeff, EIDSNESS, and Rochelle will send you that name on the chat. Kevin Wren.
Hi, thank you. I am the leader of Washington Insulin for All.
We've heard a lot about cost on this call, but not enough about the quality of life benefits, particularly for those with chronic illnesses who account for 45% of our population. Diabetics like me are rationing
Did we lose him?
I see his face and I see that he's talking. I can't hear him. Kevin?
The system exploits the chronically ill and disabled. A quarter of those with diabetes report rationing. We have over 600,000 diabetics in Washington, and a third of our state is at risk of developing it. I am fortunate to be on Apple Care. Because I am in poverty, my insulin costs $0. Without it, a month of my insulin costs over $1,000. For those without insurance, life is a nightmare when facing any health emergency or managing a condition. We need more patient representatives at this level while discussing public health priorities such as universal health care. Representation is especially important for the chronically ill. Black, Indigenous, and people of color face greater inequities in health, as well as
Kevin, I'm afraid your internet connection is spotty, so we've lost some of what you've said. If you would be willing to send your written comments to us, we'll make sure that our work group members get a copy of it. Okay, we're going through our list here, and it looks like the next several people are not here. How about Pamela Dalen, D-A-L-A-N? We'll have time to take one more comment.
Okay, Pamela, I've unmuted you.
Okay, we'll
Thank
take
you. Thank you very much. I am all out tilt for number A, and part of the reason is because of the multi-payer costs and the profiteering that goes on. And also I wanted to point out that right now with the COVID virus, the people without care, especially Latino and Black people who cannot get anything but a test for free and have no means of taking care of themselves or getting hospital care without huge debt, is endangering every single one of us. Also, I wanted to mention that the Montana state system has told their hospital systems that they will take 236% of Medicare, and that has been working for 4 years, and they have saved about $16 million a year. So it can be done, and other states are following their model. It can be done that we get control of healthcare costs from big hospital systems. Thank you.
Thank you, everyone. I appreciate it. And we got through down to the 25th person who signed up. So we were able to take quite a bit of public comment today. I appreciate everyone's efforts to make comments today and provide feedback, and our work group members for listening so carefully. And again, if you did not get an opportunity to make a comment today, please do submit your comments via the website, and our diligent work group members will see them and review them. I'd like to thank everyone for their hard work and attention today. I know Zoom calls can be fatiguing, but I think we got a lot of great information today, and I look forward to seeing you in a few weeks at our next meeting. Again, you should be expecting some more follow-up from us, but thank you again, as ever, for all of your contributions, and we'll see you soon. Take care. Be well. Bye, everyone.